Four, three, two, one. We are live now, ma'am.
Good evening, everybody. Welcome to live webinar Except from Experts. I would like to welcome all the delegates and the panelists and moderator for today's program. I am Dr. Indranil Purkar, General Manager and Head Medical Services IPCA Laboratories. I would like to welcome everybody. First and foremost, I would like to introduce the moderator for today's program. Next slide. Next slide. So our moderator for today's program is Dr. Meera Raghavan. I would like to introduce her, welcome and introduce her. She's a senior consultant urogynecologist and robotic surgeon, Apollo Hospitals, Chennai. She is an alumnus of Madras Medical College with 32 gold medals, including the most prestigious Johnstone gold medal. She trained and worked in OBS and Gynae at PGH Chandigarh, JIPMER, and also in Manchester, UK. She worked as a consultant OBS and Gynae in South Manchester University Teaching Hospital, United Kingdom. She has been a pioneer in urogynecology and minimally invasive gynecological surgery, including robotics. She is a faculty in many national and international gynecology and urogynecology forums. Also, she is an author and presenter in many international journals and also in international forums. I would like to welcome Dr. Meera Raghavan, and also I would like to request her to take over the proceedings for today. Welcome, ma'am.
Thank you very much, sir. Welcome one and all. Welcome esteemed chairpersons for today's program. Welcome all the experts who are on this panel, and welcome all the delegates. And thanks to the IPCA team, Mr. Fani Kumar, as well as Runa for organizing, and Dr. Indranil Purkait for organizing this webinar. This is a kind of a different format from the usual webinars which we would come across. Basically, we would want to hear from the experts about the management of the various domains of urogynecology stroke female urology, which is why we are going to do it as a case scenario based discussion. So each expert will be given a particular case scenario pertaining to a domain of urogynecology, and they will go through the evidence-based management, what is best suited for this particular cases, why they think that should be the reason, and how to proceed further. And we will take up the questions from the chairpersons who direct their questions to the experts pertaining to the case. And at the same time, kindly post your queries in the question box or in the chat box. So we will ask the expert the same questions from the delegates pertaining to that particular case study. So I take great honor and pleasure in introducing the experts, the chairpersons who are here. So can the host allow me to share?
Ma'am, you can share your screen.
Yeah. Can somebody share the PowerPoint for all the introductory slides for the chairpersons, please? Runa will be able to share the chairperson's introductory slide. I take great honor and pleasure in welcoming Dr. Rajesh Taneja, who's our senior consultant and advisor, urology and robotic surgery, Indraprastha Apollo Hospital, New Delhi, who's chairman, Education Committee of ESSIC, which is an international society for study on bladder pain syndrome, and founder chairman of GIBS, Global Interstitial Cystitis and Bladder Pain Society. Welcome, Dr. Taneja, and thanks so many times for agreeing to be the chairperson for this session. Hope to see a wonderful interaction with yourself. I welcome on board. Next slide. Our very own dear Dr. P.M. Gopinath, who is the Director and Senior Consultant. Welcome, sir, from Obs and Gynae Institute of Obs and Gynae and IVF, a gold medalist from the University of Madras in MD-OG, who furthered his training in the field of IVF. He's a renowned teacher for his cool head and expert skills and the way he teaches the basic obs and gynae skills during surgery, and a fantastic mentor. I've had the great pleasure of being a student, and specializes in endoscopy, both laparoscopy and hysteroscopy. Excellent vaginal surgeon. Welcome, sir, on board. Looking forward to your expert interaction. Next slide, please. Dr. Vijayalakshmi Seshadri, a renowned senior consultant gynecologist and obstetrician, a very dedicated menopause related practitioner, renowned person as far as the Indian Menopause Society is concerned, now president elect for the OXY, chairperson research committee of the Indian Menopause Society, and various accolades, including the ISOPARB and Best Award in AICOG, and contributed to the Foxy Book of Obs and Gynae, works at Sundaram Medical Foundation. Many thanks, ma'am, for agreeing to be part of this program. Again, looking forward to your expert opinions. Next slide, please. Dr. Sailesh Raina, Director of Urology, Neurourology and Renal Transplant, Jaslok Hospital and Research Center, Mumbai. Director Urology, mainly associated with President of Pelvic Floor Society, a renowned person who has keen interest in neurourology and sacral neural modulation. Thank you very much, sir, for joining with us and looking forward to your expert opinion and inputs regarding these case scenarios. Thank you. So we welcome on board this conglomeration of experts in the field of gynecology and urology to make it as more interesting. We have with us as panelists our Professor Raja Maheshwari, who is the pioneer in the field of urogynecology. Welcome, ma'am. May I request the chairperson to invite Dr. Raja Maheshwari to the panel, Dr. Gopinath to introduce madam. Is Dr. Gopinath logged in?
I have logged in. Good evening.
Yes, sir. Thank you.
I have a great pleasure in introducing the giant, Dr. N. Rajamaheshwari. And I have been following her from the undergraduate days. When I was doing my undergraduate days, she was in gynae. When I was doing my post-graduation days, she was in urology. Incidentally, even my wife was a house surgeon working with her, and it speaks volumes of her sincerity and hard work. And later, when she was heading the Department of Urogynec, where she founded the department and excelled in training and teaching. You name the urogynecologists all over India, they would have been trained under her and or associate with her or attended their workshop. We have a great privilege in inviting you, Dr. Rajameshwari. Good evening.
Good evening, ma'am. Welcome. That was a fantastic introduction to the most renowned person in the panel as far as the Urogynecology Forum is concerned. Welcome, ma'am. Thanks for agreeing to part. May I also request you to kindly introduce Professor Sita Lakshmi, sir?
And Dr. Sita Lakshmi.
Can we have the slide for Sita Lakshmi?
Again, she is a very hard-working, young, dynamic person who have been groomed completely into the urogynec under the eminent leadership of Dr. Rajamaheshwari. And independently, she has been excelling in so many workshops with the hands-on and talks on urogynecology. At present, she is heading the department, heading as a professor in the Institute of Obstetrics and Gynecology. And we welcome you, Dr. Sita. We fondly call her Dr. Sita.
Yes, sir.
Thank you, sir. Thank you so much. May I request Dr. Sailesh Raina to introduce Dr. Sanjay Sinha, please? Hello. Can we have
Oh, hi.
Dr. Sailesh Raina?
Yeah,
Yeah.
can you hear me now?
Yes, yes, indeed. Yes, sir.
It's a pleasure to introduce Sanjay. Sanjay is a very creditable and respected colleague whom I love very much. He is a scientist if there ever was one. And his interests are urinary incontinence, voiding dysfunction, besides other things. Sanjay is the chair of the Function and Female Urology section of the USI. He's the lead author of the USI guidelines on urinary incontinence. In fact, I was a part of those guidelines and I thought Sanjay did a remarkable job. He's a regional editor of the SIU Journal of Urology. And he's the associate editor of the BMC in Urology, that is the voiding dysfunction section. Sanjay, as I've always mentioned, he is beyond his years. That is, if there's one person who can call and recognize an unscientific answer from a scientific answer, that is Sanjay. I mean, he's remarkable. Welcome, Sanjay. It's a proud privilege to introduce you on this panel.
Thank you, Dr.
Thank you.
Raina. Thank you. May I now call upon Dr. Rajesh Taneja to kindly introduce Dr. Sanjay Pandey.
Hello, good evening, everyone. So I've been asked to introduce somebody whom I'm sure everyone here knows so well personally, and I know him too personally. That's what I can tell you. So he is the dynamic urologist who started his work from Tamil Nadu, got his MCH degree from JIPMER Pondicherry, then worked in Chennai before shifting to the prestigious Kokilaben Hospital in Mumbai. And there he is one of the leading urologists, not only of the country, but internationally, with his special interest in the genitourinary reconstruction, andrology, female urology, and gender reassignment surgery. He has also been pioneer for the botulinum toxin in urology. Besides all this academic thing, he is a wonderful person, and he happens to be the founder secretary of Global Interstitial Cystitis Bladder Pain Society that we founded together. So I present to you Dr. Sanjay Pandey from Mumbai.
Thank you, sir. Can I request Dr. Vijayalakshmi Sheshadri to introduce Dr. Shrikala Prasad and Dr.
Yes.
Tamar Selvi, please?
To introduce Tamil Selvi is always a pleasure because she's a great friend of mine, always ready to help. We have a common forum at the clinic side also at Mangai Women's Center, and of course at Sundar Medical Foundation. She comes as a visiting consultant as well. So it's always a pleasure to work with her. As I have seen her doing surgeries in the urogynecology, a very meticulous approach, and is also very keen at teaching the postgraduates. She has qualified from the UK and then obtained her FRCOG now. Now she's a fellow and very passionate about her and very committed about the urogynecology and of course in general gynecology obstetrics as well. So I'm really honored to have her here and we would be really thrilled to interact with her. Thank you, Tamichelli, and you are most welcome here.
Thank you so much, madam.
Welcome, Dr. Tamar Selvi. Ma'am,
Thank
may
you,
I request you to kindly introduce Dr. Shrikala Prasad? Can we have the
Yes.
introductory slide?
Yeah, has Shrikala joined?
She will be
Okay.
joining us, but
Okay, no
we can
problem.
introduce so we can
So
go with the flow.
I have another friend. Can you just change the slide?
Can we
please?
have the slide of Dr. Shrikala Prasad?
It's again Another
you.
friend of mine, Dr. Shrikala Prasad. I think she's now the head of the Department of Urogynecology at the Government Kasturba Gandhi Hospital, Triplicane. Has been there with the Urogynecology department for a long, long time. She did her MCH in Urogynecology and also worked under Professor Rajam Maheshwari Madam. And she has been the past secretary of the Obstetric Gynecological Society of Southern India as well. A very dear friend, a very lovable doctor who is always willing to help. Especially, we all know as gynecologists and obstetricians, we often require the urogynecologist's help, and she's always willing to help. So I'm really proud and honored to share the stage with her, and I'm sure we will have a very good interactive conference webinar. Now, whenever she comes, she will join us. There is a lot of welcome wishes to Shrikala.
Thank you all. Thank you, chairpersons, for introducing all our expert panelists, and welcome all our esteemed panelists to this program. We will be now starting with the case presentation. May I request the host to allow me to share my screen?
Meera ma'am, you can share your screen.
Fine. The first case study, we will start with our own Professor Raja Maheshwari ma'am. Ma'am, this is the case scenario.
Meera, sorry to interrupt. Your slides are not displaying properly. It is in a screensaver mode.
So now I have put it on.
Not yet.
PowerPoint. Can you not see now?
Not yet, Meera.
Not in a full view?
Not in the full view. Am I the only one having problem? Is it the same for everyone else?
Yeah,
No,
it's a narrow.
Meera, you just you don't stop sharing.
I'm
Open
going
your
to do that.
PowerPoint on the slide and then share again.
Sure. Okay.
Yes. Now you put it on a slideshow.
Yeah. Now, full view?
Yeah. Excellent.
Thank you very much. Yes, ma'am. This is a patient who presented, the domain which we are going to discuss now is prolapse and related bladder dysfunction. So this is a 61-year-old Paris lady, para 2, life 2, postmenopausal women, presented in the outpatient with a complaint of mass descending per vaginum for a past 1 year, only to worsen within the last 4 months because she was caring for her elderly mom. She also had the feature of feeling uncomfortable to walk and had difficulty in passing urine with incomplete emptying of bladder. Nothing else. In fact, so surprisingly, she was tolerant to most of the difficulties which she was facing and said just that she had a prolapse or something coming down, not much of a difficulty. The only important medical history of significance was hypertension, and she was on antihypertensives. This was the examination. The question to the expert, what will we look for anything in specific during the examination? Ma'am, it's for the benefit of the trainees and for people who are not practicing urogyne or female urology. Can you take us through the specific systematic examination which we would be doing at this point of time?
I think we are going to take one by one the questions. The first question is regarding the examination. Am I right, Meera?
Absolutely, ma'am. One by one.
First, I would like to thank Meera and Dr. Gopinath for his excellent introduction. Thank all the other faculty, chairpersons, and everybody. Prolapse is a very, very common problem encountered by the gynecologists and urogynecologists in their day-to-day practice. And down south, we encounter more of stage 3, stage 4 pelvic organ prolapse. When we say stage 4, stage 3, that means she has level 1 defect, level 2 defects, and may or may not have level 3 defect. So in this patient, while examining, there are few things that we need to verify. But looking at it, even an undergraduate MBBS student can say it is a pelvic organ prolapse. But only thing is, most of the faculty and the chairpersons know that the level of defect and the expected pathophysiology under it. So from the clinician's point of view, the examination, what we need to do is, number one, whether it is reducible prolapse, because from the history, it did not say whether she had any problem in reducing it. And definitely all the pelvic organ prolapse cases will have voiding problem.
Not reducible, ma'am.
Not reducible?
Yes,
Did she say the history, did it say that it could not be reduced?
She said it's been out for 4 months.
Out, okay, but
not very significantly reducible.
The patients, if you ask them, they may say that it is possible to push it inside, because
occasionally,
it appears that the bladder also has come down almost completely. So she will have the voiding problem, and they will be able to pass urine only if they reduce the mass. Otherwise, they may dribble or pass incompletely. And the first point, the Mira says it is not reducible. I don't know whether it is partially reducible or completely reducible.
I assumed it's partially reducible.
If it is completely reducible, the scenario will be totally different. So from the history, it confirms that she has difficulty in walking, probably all the symptoms related to it, and avoiding problem because of the bladder descent. And she didn't say anything about the bowel habits. Did she have any problem in defecation, Mira?
Yes, ma'am. She was telling she has to lift the prolapse. So I presume she has to splint the perineum to empty her bowel.
Okay, to complete or to even initiate it?
Complete.
Okay. So obviously, we need have to ask her about the sexual habits, because it is practically will be very difficult to anyone, and to have sexual activity. And moreover, she is 61 postmenopausal, but still we need to inquire her about this. And any associated neurological problems, say the anal tone, rectal tone, that is very important, because all the time when the patient has voiding problem, we always presume that it is because of the prolapse. Yes, to an extent, yes. But supposing there is a neurogenic element also there, we need to look into it. On clinical examination, we need to do it. Second thing is, when you reduce the prolapse, we have to check for the stress urinary incontinence. So in this patient, you can't really make out the transverse sulcus. You can't really look into the rugosity. Only thing is, the prolapse shows it is almost a stage 4 pelvic organ prolapse. Maybe with some pressure, you can reduce it. I can see just below the urethra, there is a slight bulge, and then there is something like a transverse sulcus, probably partly obliterated. Then you have the elongate anterior and posterior. Posterior vaginal wall looks slightly longer than the anterior vaginal wall. The cervix appears congested, and there is no decubitus ulceration or any such thing. And then we have to look, please ask the patient whether she had any stress incontinence prior to the development of prolapse to this extent. But many of them, they will have stress urinary incontinence initially, which as the prolapse progresses will become less and less to an extent. Once she develops stage 3 or 4 prolapse, there will not be any incontinence, stress incontinence at all, even in the presence of sphincter incompetency. which we need to check on it. And what I normally do is, this is not enough. This office examination is not enough. So routinely you do all the urine and blood biochemistry and other things, the basic things. I always do an ultrasound KUB examination, and then I will check the post-void residue. I always reduce and check for stress urinary incontinence. And in our protocol, when the patient has a mixed, say, kind of LUTS, we also take them for the examination in the minor theater with, if needed, combine the cystoscopic examination, and then we plan for the rest of the things. Imaging studies, there is absolutely there is no need. You need to select your case. Supposing your patient has hematuria, or if the urinary problem is not pointing to any particular condition, or you need to select your cases for higher imaging evaluations like CT scan and other things. Normally, the ultrasound KUB with estimation of the post-void residue and the examination in the theater, if needed with the cystoscopy, will help the clinician to plan for the type of surgery and the type of procedure that you need to combine for this patient.
Ma'am, would you consider asking specific bladder related questions to this patient? Because she is not just forthcoming. Her main concern is the prolapse is there for a long time. Many patients do not come forth with those kind of symptoms. So what specific bladder related questions would we ask so as to plan our further plan of investigations or management?
See, there are only two types of problems in urology. One is the storage stage and the voiding stage problems. In the storage, the one is the stress incontinence and the sphincter incompetency will be hidden, masked because of the prolapse. So that even if you put out leading questions and ask them, and she will not be able to tell us whether she has the stress urinary leakage. So that is ruled out. And the second thing is the voiding problem. She may say, hesitancy, poor stream, passing in, with low volume, and sometimes straining worsening the voiding. So many of your patients will say the more she strains, the more prolapse will come down. The bladder will be dragged down, and it will further hinder the voiding phase. So many of them, if it is reducible prolapse, if they reduce it and then they void it, it may be possible for them. So all the avoiding symptoms like all the hesitancy and poor flow, prolonged flow, difficulty and straining, all those things, and related features of urinary infection also may be there. There can be, in the last USA meeting, we were discussing about how prolapse and overactive bladder symptoms can be related, because the prolapse by itself can lead on to the detrusor changes and the obstruction and the related overactivity and the bladder symptoms can be there. And the third stage is the underactivity of the bladder. So patients with the prolapse and long-term prolapse, particularly, please, 1 minute, if you don't mind. There is an urgent call. I'll just call you. Sanjay. Message. Hello.
Yes, ma'am.
Yeah. So we have to the storage phase, voiding phase. In the voiding phase, or other than the outflow tract obstructions, you may have to ask for detrusor, the hypocontractile function. The patients, that can be assessed only with, maybe reducing the prolapse and doing the aerodynamic study, pressure flow studies, or in the post-operatively one can confirm it. So these are all the three things. And the hypocontractility also will result in a voiding problem.
Overflow.
So the overactivity will have the incontinence problem. The sphincter incompetency will be masked because of the obstruction and urethral kinking. So the more than that, so the patient may not be able to volunteer and tell us about their storage phase symptoms or voiding phase symptoms, but it goes without saying, looking at the size of the prolapse, looking at the extent of descent of the prolapse, so almost 99% of the patients will have all these symptoms.
Thank you, ma'am. So this was the reports for the patient. So this was the diagnosis. So the question is, if there was concurrent incontinence, like in this patient, which can be masked, but which is revealed, how will we investigate and prove it, and how would we manage this patient?
There is again the question of the role of urodynamics, and it is a bit controversial, and it is not necessary to do urodynamic study for all those the patients who have pelvic organ prolapse. Certainly, it is worthwhile reducing the prolapse in all the women, and then checking, at least keep them half filled, and then check whether they have any positive cough stress test. So that is very, very important. If cough stress test is present, it is fine. So supposing yes, some people may have the overt leakage, some people may not reveal it. Then you need to look for the occult stress incontinence. So in both cases, we discussed the possibility of post-operative stress incontinence manifesting to the patient, which can occur in a higher percentage, say up to 80%, the higher the stage of the prolapse, and the higher the likelihood of she developing the sphincter incompetence. I mean, I should say it is revealing the sphincter incompetency and stress urinary incontinence. So what we need to do is, in our routine protocol, we just reduce the prolapse, and we just see at least she retains some 100 and 200 ml of urine, and then make a cough and do the cough stress test. And that is will tell us. And what I do when I combine the EOT and the cystoscopy, I check the cough stress test, do it with a full bladder and with an empty bladder. And if the prolapse is reduced, and even with the empty bladder, if they reveal stress leakage, then it certainly points out that she may need combining an anti-incontinence procedure along with that. So that is, I think it is worth. And we have to counsel the patients regarding the need for anti-incontinence procedure later on. Either we can offer her as a single sitting correction, or we can counsel her and she can observe her after the surgery for a pelvic organ prolapse. And if she needs it, she can have a second stage anti-incontinence procedure. I think it would be wise on the part of the surgeon to counsel the patient, explain the possibility of developing developing the stress urinary incontinence, which was hidden earlier. And because it should not be a surprise to our patient, she should come forward. Say, she should mentally be prepared for the possibility of realizing the stress leakage after surgery if pelvic organ prolapse repair reconstruction alone is considered. So that is very important. And certainly all the outflow tract obstructions will be relieved. And the overactive symptoms, say urgency, urge incontinence, will definitely subside. Regarding the hypocontractility, and there are studies which says even that recovers. So on the whole, the symptoms of overactive symptoms and the hypocontractility, everything improves. But if the pelvic organ prolapse is a long duration problem, and it has interfered with the detusar activity, then it may not be completely reversed in all the women. I think it is our responsibility to make it clear to them.
What would be your choice of procedure for this patient?
So 61 year post-menopausal, almost sexually inactive, with not much of medical problems. And I think in this patient, did you do an ultrasound? Is her uterus size and endometrium, everything is fine, Mira?
Yes, yes, yes.
What?
Atrophic endometrium.
Okay. So
Atrophic uterus.
no
and
occult or overt incontinence, stress incontinence?
no, she had a urodynamics, and that was what was.
So we say urodynamics. It is technically difficult.
It
So
is.
we need to reduce it, keep a plug in the
We put a pessary,
in
kept it in, and then
you
put
know,
it.
and then you make a cough with that, and then every time she coughs, sometimes the pessary may come off or the pack may come off. So it is technically, it's almost half torture for the patient to go through a urodynamic study with a pelvic organ prolapse reduced and all those things. It is technically difficult. And I think I will just discuss this. And if there is overt stress incontinence, if the patient is willing, I will consider doing a vaginal hysterectomy with repair reconstruction and an anti-incontinence procedure.
There was
And
no
the repair
incontinence.
reconstruction, I mean addressing to the level 1, level 2 anterior, level 2 posterior, and in level 3, if there is sphincter incompetency, mid-urethral sling. If the patient leaks urine with almost completely empty bladder, I will rather go in for a retropubic mid-urethral sling. And how much is the perineal length, Mira?
You mean the
perineal
perineal body?
Adequate?
2.5 to 3 centimeters roughly.
So that is, see, number one is checking the rectal tone, anal tone. That is one thing. Second thing is the perineal body. Many of them have a very short perineal body. And you need to narrow the hiatus, because a wide genital hiatus is one of the cause for the recurrence in future. So when we are planning the repair, so the posterior raphe, and normally we don't do the liver tap ligation, but still we can do a good perineorraphy so that the genital hiatus dimensions are reduced.
Ma'am, is colpoclysis a choice for this patient? And if so, what one specific precaution would you take while considering that as an option?
See,
for the same reasons discussed. She's aged, she's menopausal,
see,
she assumed
everything
she's
is fine. You said your patient is 61. Okay. So with the increased longevity, we cannot say that 61 is...
no.
Okay. So I have done colpoclysis for patients who are 95, 96 and all. Occasionally, even for slightly younger patients. One thing is you need to rule out the endometrial or uterine pathology or any other adnexal pathology in these patients. Okay. Number two is we need to always, we plan for a partial modified colpoclysis, and it should always be combined with a high colpoperneuraphy. These are the two important things.
Sure. Any specific point? Yeah.
Because in the partial colpoclysis, there are two channels left behind.
Correct.
Through which you can screen your patients even post-operatively, pap smear or hysteroscope or whatever it is.
Sure. Any specific issues about how pre-op management would be optimized to get the best results for this patient, ma'am?
So, I think Mira wants me to say the pre-operative topical, conjugated estrogen. So it is, you need to use your discretion if the vaginal wall is dry and, if you think the estrogen is going to improve the blood supply, everything, it is worth using the topical vaginal cream for the patient. That is one. Only thing is, I already said, Meera, many times we have encountered patients with stone in the urethra, stone in the bladder. So the ultrasound is very, very important. And particularly, you reduce the pelvic organ prolapse and then do the ultrasound. So in one go, you will assess the upper tract, the kidneys, and whether they're invariably most of them will have hydroerythronephrosis with this kind of prolapse. So we need to exclude the possibility of other factors also. So I think you have to exclude stone problem and then other neurogenic problems. And it is because many times I have seen the neurogenic problems resulting in urinary retention even after surgery. We have to explain to the patient the reason why she is not able to completely empty even after the pelvic organ prolapse surgery.
Anything related to mesh, ma'am? Considering the degree of prolapse here, would you ever consider the use of mesh, or you've completely said no to it, considering the current scenario about mesh?
So I think I will.
The very reasons that longevity is there, and she's only 61.
That is the reason. The longevity is there. She is 61. So we don't want her to have complications related to mesh, because we are very comfortable with autologous tissues. So we believe that the uterosacral ligament and other things which the patient has is as good as the synthetic mesh that you borrow, which is likely to lead on to more complications. If at all the autologous tissues fail, if you anchor the vault to uterosacral ligament or sacrospinous ligament or whatever, anterior longitudinal ligament, whatever it is, so the problem will be maximum, it will be a failure. Whereas if it is a mesh-related procedure, other than failure, there can be mesh-related complications, which we are answerable. So in this particular patient, I don't think there is any need for a mesh procedure, provided you can focus, concentrate, and do the repair and reconstruction using the patient's own tissue.
Okay, ma'am. So this patient ended up, as we said, vaginal hysterectomy, and she had the whole of the omentum prolapsing. So it was a vaginal omentectomy, anterior repair, a pelvic floor repair for the posterior wall, a cystoscopy, and a sacrospinous fixation to look after the level 1. She did not require anti-incontinence procedure because of no demonstrable overt or occult stress urinary incontinence. So what
Why
will
was
be
omentectomy, Meera? Why
the whole thing
omentectomy?
was prolapsing. It was a large
Why should we
enterocele.
do omentectomy? Can't we just reduce it and leave
We
it?
tried reducing it. It was completely necrosed at the portion which was hanging out
Of
for a
course,
long time.
necrosed portion should be
Necrosed
removed,
portion.
but not all the omental seal.
Necrosed portion,
yes.
because hanging because of the congestion which was happening for a long time. Any specific plans to prevent prolapse in the future? Because we know that a third of the patients can have recurrence. So any specific steps
See,
and technicalities?
if you have done the sacrospinous ligament fixation, because this being a posterior fixation, the brunt of the pressure effect is transmitted anteriorly. The chance of this patient developing anterior compartmental defect, particularly the cystocele, is there. That is, it can be as high as 37% as per publications. So we should make sure that there are 2-3 things that are important in any surgery. That is, we don't want recurrence, number one. Number two is we don't want complications. With sacrospinous ligament fixation, if at all the maximum we can get recurrence, particularly in the anterior compartment. So I think if someone is familiar with the high uterosacral ligament suspension, and they can combine anterior defect repair, posterior defect repair, and in our experience, it is very effective. Initially, maybe before learning high uterosacral ligament suspension, we all got familiarize ourselves with the sacrospinous ligament fixation. It is much easier. The learning curve is quite shorter with sacrospinous ligament fixation. Only thing is this, I have seen recurrence in the anterior compartment. Again, promptly the patient will come back to you and we will feel miserable seeing the recurrence. So we need to resort to other procedures. So I think one should direct specific care and attention to correct the anterior defect if you are doing the sacrospinous ligament fixation.
Thank you, ma'am. Dr. Gopinath, would you like to ask
Yes, yes,
Professor any questions regarding this particular case, sir?
sure. Dr. NRM, we fondly call her as NRM. We have been seeing prolapse as a gynecologist for a long time, and the urogynecology is a new development focusing attention in specific in terms of prevention and then complications of the prolapse. So for a person who is graduating as a gynecologist, what are the special set of skills they should acquire or possess in handling cases like this?
I think it is I should say it's a very broad way. It is difficult to answer your question, sir, because the understanding, the approach, repair, reconstruction has changed over time, particularly in the last 2 decades, because I have been a gynecologist. I remember I was a senior house surgeon when you were a senior house surgeon. As you said, your wife was with me, working with me in Institute of Obs and Gynae. She's a very good, worker as a CRR. I'm sure she'll continue to be the same. See, and I was working as a gynecologist. I have, and then I just changed the specialty and became the urologist doing female urology. I know what are all the mistakes I did when I was a general gynecologist, what are all the mistakes I did when I was a general urologist, and what we learned subsequently. So the approach, understanding, it's a phase of evolution, I would rather take pride in saying, yes, this is a phase that all of us, we have to go through in this. So what I understood as prolapse, as a diagnosis management in my undergraduate days, my postgraduate days as a gynecologist, and subsequently when I was in urology, it is totally different. Everything has changed. So whatever as general gynecologist I learned, I have to unlearn and relearn things. So I think when you were there in institute also, we were posting our postgraduates in the specialty. I think right now they are getting posted with Srikala, and we just train them in our way. Similarly, we post the urologists also to work with us so that they also will have the orientation. So it is, there is so much to do as a OBGY person. There is too many things for the OBGY specialist to handle. So it is, we just take only one part of it and we focus on it. So we have more time to focus, develop, and do many things. I think the undergraduate or graduate or postgraduate, a special training is worthwhile in before getting qualified as a specialist or whatever it is. I think I'm not able to completely answer your questions. It's
Dr. Vijayalakshmi, ma'am, you want to ask madam a question?
Ma'am, I know you have a long history through decades. I just wanted to know, when you started off, were you still doing routine salpingectomies? Are you doing now? Because along with vaginal hysterectomy for when we are also doing, but because we know now the fimbrial cause for ovarian malignancy, is that the cause for changeover, or what is your opinion on that?
Thank you, Madam Vijayalakshmi. That is a very nice question. And a risk reduction salpingectomy, invariably we combine it. We combine the bilateral salpingectomy. And in postmenopausal women, if the ovaries are atrophic and if it is highly placed, we just leave it. Otherwise, if they have some postmenopausal bleeding, spotting, and other things, even though the workup comes as negative, we do the oophorectomy, bilateral salpingo-oophorectomy. Even otherwise, the risk reducing bilateral salpingectomy is combined with all our cases.
Thank you, ma'am.
Thank you very
Ma'am,
much
one
for
more
pointing.
small question, Meera. In case, ma'am, you say like for estrogenization in certain postmenopausal women where it is required, we give estrogen, local estrogens before pre-operatively. Then does it vary as an individual, the dosage, the duration, or do you have a particular protocol you can give for some
See,
time? And does it increase the bleeding during surgery?
I think the pre-operative vaginal estrogen cream application for say 2 to 3 weeks before surgery normally helps the patient to develop good tissue texture. It doesn't really enhance the blood loss. But whenever we give the estrogen cream, all of us, we have some, hesitation in prescribing estrogen to our women, particularly those who have the uterus. But we know from the evidence that the cream, vaginal cream, is not enhancing the chances of endometrial CE. So certainly we can say 3 to 4 weeks before surgery using a estrogen cream is going to only improve the local blood supply and tissue texture, and it is not going to adversely affect.
Thank you, ma'am. Thanks.
Just 3 take-home messages for benefit of everybody. One important pre-op, one important intra-op, one important post-op. So we close the case.
Number 1 is thorough evaluation. Don't forget to assess the upper urinary tract. The minimum is the kidney, bladder, and the pelvic area scanning, which helps you to diagnose most of the problem. And then look for the stress urinary incontinence. You need to take care and exclude the presence of sphincter incompetency. That is preoperatively. During surgery, I would say that we have to plan a very meticulous repair. Whenever you do as undergraduate, we all were trained that vaginal hysterectomy is not the treatment for pelvic organ prolapse. It is the repair and reconstruction which is the treatment. So the hysterectomy is an adjunctive procedure we combine along with that. So what is very important for us also to teach them is we need to address the different levels, the apical attachment. You need to attach the vault or the apex either to the uterosacral ligament as McCall's scaldoplasty, or as high uterosacral ligament suspension, or sacrospinous ligament suspension, in whatever form. So you need to address the apical attachment. It's, as per evidence, it is a must that all the apex should be suspended. That is one. Number 2, if you are doing a posterior repair like sacrospinous ligament fixation, you need to address the anterior repair. It should be well repaired. Otherwise, the chances of developing anterior recurrence is pretty high. What is the third one you want, Meera? Post-op.
Post-op. One
post-op. Post-op, in my routine protocol, when we remove the catheter, say 24, 48 hours or 32 hours, I always check the post-void residue with ultrasound.
Absolutely.
Because particularly when you do the so-called meticulous repair of the anterior cystocele, many of them are likely to have the voiding problem because of the post-operative edema, congestion, pain, or whatever it is. So I always request the duty doctors to check the post-void residue in the post-operative period. And laxatives, now requesting the patient not to strain on stool for quite some time. And that is a regular.
Thank you very much, ma'am. That was completely comprehensive and wonderful management and very good take-home points. Thank you very much. Thanks
Thank
for
you,
joining.
Meera. Thank you.
Thank you, ma'am. We will then move on to the second case. I would now invite Professor Sita Lakshmi. So we will share the second case where it is, just give me 1 minute. Are we seeing the slides in full mode?
Yes, ma'am.
Yeah, thank you. So this patient is a 55-year-old para to lifetime woman, a case of status post-TVTO 3 years back for severe SUI. She was absolutely without incontinence, free from it for 1 year postoperatively, now presented with complaints of stress urinary leakage associated with cough, exercise, and laugh, which has got worsened over the last 2-3 years. Medical history, bronchial asthma for 15 years on inhalers, diabetes mellitus, and hypertensive on antihypertensive. So, Professor Sita Lakshmi, how will we now start evaluating the patient? And what could you potentially think would be the reason for this recurrence, if at all it is recurrence? Ma'am, unmute yourself. Yeah.
Yes. Good evening.
Welcome and thanks for joining.
Respected chairpersons, dear friends and colleagues, good evening, everybody. I thank Gopinath sir and Dr. Meera for kind introductory words. And the question is, already the patient has undergone TVT, isn't it?
TVTO.
And TVTO, and now the patient has recurrence of urinary incontinence.
Yeah.
So probably the first we have to, before starting the management, we have to be very clear that what kind of stress urinary incontinence the patient has, whether it is a hypermobility of urethra or intrinsic sphincter deficiency. Suppose previously this patient had intrinsic sphincter deficiency and the management with the TVTO was insufficient to correct the intrinsic sphincter deficiency. That may be one of the reasons. Now again, the patient has recurrent stress urinary incontinence. So we have to always evaluate completely whether the patient has hypermobility of urethra or intrinsic sphincter deficiency. Now I will evaluate the patient with ultrasound imaging of kidney, ureter, and bladder with pre-void and post-void, and cystoscopy, and along with urodynamics.
Could it be overactive bladder, which she is thinking as incontinence due to cough and stress?
We have to evaluate whether the patient has recurrent stress urinary incontinence or overactive bladder by complete history taking and by going through the voiding diary and then the other investigations. Voiding diary is very important, at least minimum for a period of 3 days.
Thank you. So on physical examination, this is what was seen. There was urethral mild hypermobility, no mesh erosion, and bladder and vagina were normal. Severe stress urinary incontinence, Bonnie's test positive, and excellent Kegel contraction was elicited when we asked her to contract the pelvic floor. It's not that it was lesser than any grade 2. This was the study on urine analysis, so completely normal, and ultrasound kidneys were also normal. So now how will you investigate, and what else would you need to do when you repeat the UDS? Will the uroflow give you an idea, and any specific imaging would you ask?
Yeah, I will go with, apart from the routine urine analysis and ultrasound KUB, I may repeat cystoscopy to know whether the mesh has been eroded into the bladder or urethra. And then definitely I want to repeat the urodynamic studies, and which will give the idea of uroflowmetry. The uroflowmetry will tell us what is the flow rate, maximum flow rate, and along with post-void residual volume. So the uroflowmetry is a must, which will come under the complete urodynamic evaluation. And imaging, I don't think any specific imaging I will go for except for ultrasound KUB and pelvis with pre-void and post-void.
What about transperineal imaging in specific for
Yes.
looking for the mesh?
Yeah, that is
The sling,
also
sorry.
that is also good. Transperineal ultrasound also good if to know the extent of the mesh, and it will give idea about the position of the mesh and other things about the mesh.
Particularly
Transperineal
that
ultrasound.
given that it is a TVTO, is there anything specific you would look for when you're doing a transperineal imaging for the sling? Is there anything we are worried about?
And I don't have much experience in transperineal ultrasound using the TVT mesh or some other mesh. But if I do so, I have to look for specifically, I will look for the erosion or extension of the mesh into the bladder neck or the urethra.
Okay. So this was the thing which was present. She also had leakage on cough, but there was associated detrusor activity during cough, and the bladder capacity was 410 ml. So with this, we have done the urodynamics. What would be your diagnosis, or what would be your impression after the evaluation, and how would we proceed further?
Did she have any stress urinary leakage in the urodynamics? You have not mentioned that. You have mentioned only the detrusor
No,
overactivity.
She
had leakage. What
Yes.
is the ALPP, intra-abdominal leak point pressure?
60.
What was the 60? So it means that she has severe stress urinary incontinence, isn't it?
Yes.
ALPP is 60 centimeter of water along with the detrusor overactivity. So if we have to ask the patient whether which symptom is more bothersome, whether recurrent stress urinary incontinence is more bothersome or the detrusor overactivity is more bothersome. So which symptom is worse, which will be treated first and followed by the management of stress urinary incontinence. Suppose if the patient has overactive bladder symptoms which was bothering her much, we have to give some anticholinergics after excluding the post-void residual urine, and then the stress urinary incontinence can be corrected.
Would you prefer anticholinergics or anything else for this particular patient?
In this patient, she has as far as the evaluation shows recurrent severe stress urinary incontinence along with the detrusor overactivity, and the neurogenic cause should also be excluded for the detrusor overactivity and the stress urinary incontinence. If she does not have any neurological problem, and the detrusor overactivity can be corrected with anticholinergics followed by the correction of severe stress urinary incontinence.
Say she's already on anticholinergics.
Yes.
Would you want to proceed with the surgery while she's on anticholinergic?
Yeah.
Or would you want to stop and then see?
Yeah. I want to stop the anticholinergics for a minimum period of 4 weeks. Then I will do the surgery. And after surgery, if it is needed, I may use it.
Why do you think we need to stop it? Any rationale?
Yeah, there is a rationale that even before doing urodynamics, anticholinergic should be stopped for a period of 15 days. That was the literature says. So before surgery also the anticholinergic should be stopped, because we don't know if the patient develop any retention of urine following surgery. We don't know whether it is due to the anticholinergic or due to our surgery. So definitely it should be stopped before surgery or before urodynamics.
So to avoid this possible effect on the bladder contractility and thereby retention, is there an alternative to the anticholinergic for detrusor overactivity which you would consider, or you would prefer only the anticholinergic?
No, we can try with diet modifications and some Kegel exercises and some liquid intake, avoiding the coffee, tea, and beverages, and the irritants, bladder irritants. We can try for some time, a minimum period of 4 to 6 weeks. If the patient does not respond to the conservative management of overactivity, then we may go for anticholinergics.
Okay.
Fluid intake chart, Kegel exercise, avoidance of bladder irritant, bladder training, everything can be tried.
So this is what was assessed and an impression was made. So do you routinely need to do urethral pressure profilometry is this very important to consider in this particular case, given that it is a recurrent SUI? And what will you do for this patient?
Urethral pressure profile, if it is done, it is very good. But in the pressure flow test, intrinsic sphincter deficiency can be diagnosed when the ALPP is very much less than 60 centimeter of water. We can diagnose the intrinsic sphincter deficiency. And before planning, I will counsel the patient what is the type of surgery which I am going to do, and what are the post-operative sequelae the patients will have. So everything should be counseled with the patient in detail before taking the patient for the further management. And the choice of procedure, I think as per the evaluation, the patient is diagnosed to have intrinsic sphincter deficiency. So I will go for pubovaginal sling with rectus fascia for this patient, which is a good option for recurrent SUI, that too with a failed transobturator tape. So I go for a pubovaginal sling with rectus fascia.
Is there any merit in considering a retropubic sling, though not a pubovaginal sling? Though pubovaginal sling is technically retropubic, would you consider a TVT or a retropubic sling in this patient as a, because it's only a TVTO, which is why I'm asking this question.
Yeah, retropubic sling can be tried, but now the mesh is very much contraindicated in many places. So when the pubovaginal sling gives equivalent result or better result with that of the retropubic sling with mesh, my option is to go with pubovaginal sling with rectus fascia.
Okay. What if the patient had a reduced flow rate? What your choice would be pubovaginal sling?
Suppose if the reduced flow rate if the patient has more of stress urinary incontinence, which is not due to the neurogenic cause, then I will go for pubovaginal sling with rectus fascia.
Okay.
If she does not have any retention of urine, voiding difficulty, and there is no trabeculation, and no significant post-void residual urine, no neurogenic cause, then I will go for pubovaginal sling with rectus fascia.
What is the role of vaginal estrogen therapy in these cases of SUI, ma'am? Could you elaborate on the
in this
evidence?
case? In this case, she has severe recurrent SUI. I don't think she will respond to vaginal local estrogen cream, but it can be applied. But I don't think it will give you a good result. It is not due to hypoestrogenism. It is due to intrinsic sphincter deficiency, which will not be effectively treated by the application of the local estrogens.
Say this patient is not willing for surgery, or her asthma, which we have seen is a primary risk factor, not under control. She's requiring steroids and stuff. How could we potentially manage this scenario, ma'am?
Then I will treat the overactive bladder first with anticholinergics, and then I may go for some urethral bulking agents.
Is there any role of medical therapy?
Medical therapy, no medical therapy for stress urinary incontinence, but overactive bladder can be treated by anticholinergics, and stress urinary incontinence can be treated by the urethral bulking agents, injection of urethral bulking agents, which will give you relief for a period of 6 months to 1 year. Then we can reassess the patient.
Okay, how effective is it, and any particular complications which one can face, and how can we follow up those patients?
With bulking agents, usually the patients may go for transient urinary retention, which will be sometimes which may require some Foley catheterization for some weeks, and most of the time it will be effective until maximum for a period of 6 months to 1 year. After that, the stress urinary incontinence may recur. So we have to counsel the patient that it will not give a 100% result with the urethral bulking agents, and patients may have a recurrence after 6 months to 1 year.
Would suspension be on cards at all? If not, why?
Birch colpo suspension can be tried, but recurrent stress urinary incontinence, my first option is the PV sling with rectal fascia rather than the Birch-Colpo suspension.
And what would be the potential retention rates with the PV sling, ma'am, compared to a retropubic mesh or a sling?
Yes, I am working in a public hospital and we have done a lot of cases of stress urinary incontinence with intrinsic sphincter deficiency. The case selection should be correct and the placement of the pubovaginal sling with rectus fascia should be correct, and with the 5-year follow-up, we do not have any retention of urine or recurrence, and our success rate is very high. To be honestly speaking, the success rate with the PV sling with rectus fascia in 5-year follow-up is very good.
So thank you very much. This was the follow-up of the patient. She had anticholinergic medication because of her severity of the detrusor overactivity. She continued to perform the Kegels exercises. All the fluid management treatment was given, a pulmonology reference, and she had a review and then subsequently had a pubovaginal sling. Did not have retention. The catheter was removed after 24 hours and she had a trial without catheter, which was successful. PVR was less than 100. She was discharged. Thank you very much, ma'am.
Thank you.
Dr.
Thank you.
Shailesh Raina, any specific question to Professor Sita Lakshmi pertaining to this case? Dr. Shailesh Raina? Dr. Gopinath, sir, would you like to ask any particular question pertaining to this?
Can you hear me now?
Yes, sir.
Can you hear me now? No, I think you've been managed extremely well. One thing is for sure that if it's a recurrent SUI, we will always do a UDS before proceeding further. And I think bladder instability to be controlled before you go for a sling or a Birch-Colpo suspension. The fact that, in a Birch-Colpo suspension, once you have failed a TVTO, I've done Birch-Colpo suspensions and I've done pubovaginal slings. There is no doubt that pubovaginal sling stands a better chance of long-term operating than a Birch-Colpo suspension, especially after failure. Birch-Colpo suspension, there is more chances of a retention and more chances of patient not being able to empty the bladder fully compared to a pubovaginal sling. The only thing with a pubovaginal sling is this autologous fascia. This lady is not really old, is she? I don't know the
55.
age. 55. So 55, I think you've done the right thing by doing a PVS, because at 55, you have good fascia. If she was very elderly and she did not want anything else, then perhaps a Birch could have been considered. But 55, I think the pubovaginal sling is the right thing to do.
Thank you, sir. Again, Professor Sita Lakshmi, 3 take-home messages which you would like to give the audience pertaining to this case when you are faced with a recurrent SUI.
Yes, the diagnosis must be very correct, even from the history taking, what type of stress urinary incontinence the patient has, whether hypermobility of urethra or intrinsic sphincter deficiency or a combination. So the history taking, evaluation, diagnosis of stress urinary incontinence is very important. And then number 2, the selection of surgery, whether the patient really needs surgery for stress urinary incontinence or the patient can be medically managed. Which symptom is bothering much to the patient, whether urge urinary incontinence or stress urinary incontinence. And sometimes the patient may mistake the urge urinary incontinence as the stress. So this differentiation should be maintained very carefully before planning any surgery. And intraoperatively, if any sling surgery, especially the PV sling is used, the sling should be appropriately placed. It should not be too tight or too loose to give a better stability of the bladder neck or the proximal urethra. And postoperatively, the patient should have a bladder training and should continue the Kegels exercise. And these are the important take-home messages for patients with recurrent stress urinary incontinence.
Thank you very much.
May I add something here, if it's all right?
Sure, sure.
I was pretty impressed by the fact that she said that she will do a transperineal ultrasound. Whenever we have put any of these tapes, whether it's a TVT or a TVTO, and we are going back in for another surgery, I think the position of that tape is very important. Invariably, these tapes go up and we think we'll do a TVT and the tape is lying right there. And finally, I think the crux of the whole thing is that Kegels exercises, the pelvic floor exercises have to be continued for a long time, whichever sling has been put. And the Stamies needle we used to have in the good old days, these Stamies needles are very good for putting a pubovaginal sling. It helps to put the pubovaginal sling. Yeah. Thank you.
Thank you, sir. Thank you very much. Thank you, ma'am.
Thank you. Thank you. Thank you very much.
Thank you. We'll proceed with the next case. I would now like to invite Dr. Sanjay Sinha, if he is there. Welcome, sir.
Hi,
Thanks for joining. Thanks
Pleasure.
to Dr. Sanjay Sinha and Dr. Sanjay Pandey, who have shelled themselves out from another webinar, as usual.
From one Dr. Raghavan to another.
Oh, really? Okay.
Good.
So you're the doyen and the expert in this particular field. Urodynamics is your niche. So I picked up a case for that. This patient is a 60-year-old parative woman with a 5-year history of difficulty in passing urine with incomplete emptying of bladder. Also complains of urgency and urgent continence occasionally. Recently developed acute urinary retention with increasing trends in the renal parameters, for which she was catheterized. 5 years she's been using the clean intermittent catheterization on and off, according to the local physician advice, never presented properly to a urologist. Also presented with claudication pain in her legs. So could you take us through a systematic examination of this patient? How would you do clinical evaluation? And also the role of frequency volume chart and what else we need to look at for a detailed evaluation?
Right. So clearly a detailed clinical evaluation includes a detailed history and a good clinical examination. And the history pertaining to especially all the other organ systems which could potentially be involved in any voiding dysfunction. So history pertaining to the gastrointestinal tract, does she have a history of constipation? She has a history of claudication. Whether this is a neurogenic claudication or a vascular claudication might give us some clue as to what the underlying pathology might be. So for all patients, not just voiding dysfunction, even if a woman or a man comes with storage symptoms, it's a good clinical practice to ask them for a history of low back pain, to ask for a history of radiating pain in the leg, to ask for neurological paresthesias or numbness in the lower limbs, all of which might point to an underlying neurological pathology. Whether the patient has a long-standing diabetes could again give us some clue as to whether there's some underlying pathology. So a good clinical history to see whether there's constipation, neurological symptoms. Often some of these things will stare you in the face when the patient walks in. What's the gait of the patient? What's the patient's cognition, cognitive function, and so on? What's her hand control in case you need to put her on CIC? Does she have good family support in case she needs it if she has some amount of difficulty with her day-to-day activities? In terms of the clinical examination, again, the clinical examination should include everything pertaining to all the pelvic organs. That means we should be looking at the urinary tract, the vaginal and the genital tract, and the anorectum, and a basic neurological assessment. So we like to call it a focused urological exam, which is a kind of a shortcut to doing a neurological examination. But each patient must have the appropriate neurological assessment to make sure that you've satisfied yourself that the patient would not be having a neurological underlying pathology. So I think all this, and of course, we could go on and on about all this. So maybe to short circuit this, at least on the clinical examination, you should be looking at the anal tone, the bulbocavernosal reflex. You should be looking at the local vaginal exam as to whether she has an obvious pathology when you see her vaginally on the speculum exam. Does she have any prolapse which could explain the obstruction? What does the urethra look like? And depending on the background history. So I think a detailed clinical evaluation is the background fundamental to the assessment of this patient. In terms of the frequency volume chart, it's important in any lower tract pathology, especially if the storage symptoms are dominant. If voiding symptoms are dominant, it may not be that important, but it's still required because some of these patients, you might get a clue to their problem by looking at the chart. So let's say a woman says that she's having a lot of voiding difficulty, and you do an ultrasound scan and you find a 600 ml residual urine, and you find that her 24-hour urine volume is 5 liters. Then it's obvious that she has probably been having chronic overhydration, chronic overdistension of the bladder. And that might give you some clue as to how to manage her. So I think it's important to get some assessment of the volumes, even if the patient has a voiding rather than a storage predominant presentation. In terms of imaging, at the bare minimum, we would like to have an ultrasound scan with the pre and post-void bladder volume. And I would usually combine that with a non-invasive flow test. So some of the basics, now she had renal dysfunction. So this patient obviously is a more serious, so to say, class of patient, because she is showing consequences of her problem in terms of upper tract changes. And here I might add that in general, patients develop upper tract problems primarily if they have storage abnormalities. So because I think the audience is at least has a significant number of gynecologists, I must clarify that the lower urinary tract has two functions: to store urine and to pass urine. In a 24-hour period, we pass urine for maybe 10 minutes. The rest of the 23 hours and 50 minutes, we are storing urine. So what happens during storage has a far greater consequence on the upper tracts compared to what's happening during passing. So it's been shown, and in fact, we published this paper in men, not in women, very recently in the Neurourology Urodynamics, showing that isolated bladder outlet obstruction without storage abnormalities does not lead to hydronephrosis, not associated independently with hydronephrosis. So if she has developed upper tract changes, I would suspect that she's actually got a storage abnormality, or she had severe underactivity with chronic large volume retention for long periods of time. So that's another situation where the upper tracts get damaged. So in this patient, to start with non-invasive evaluation, an ultrasound scan with the pre and post-void bladder volume, baseline renal function. We'll also need to look at things like her blood pressure, her proteinuria, and also I'm not trying not to digress. There are a lot of areas where we can keep on discussing. And in this patient, if we have, because of a history of claudication, I would actually ask for a neurology consult. And I might actually image her spine if I have the slightest doubt, especially if it looks like a neurogenic claudication.
Okay.
Sorry,
Wonderful.
a long answer.
No, perfect. That was exactly what it is. So symptomatic lumbar canal stenosis with nerve root compression, which she has been advised surgery for the same, but sent to me for further management, not on any medications, was very skeptical about the spinal surgery herself. So she had a Foley's catheter in situ, but normal external genitalia, urethra, bladder, vagina normal, perineal sensation and reflexes normal, a good Kegel contraction, in fact, more spasmodic, was elicited, and no prolapse. Plenty of pus cells, E. coli, creatinine was 1.7, which had crept up over a month's period time. Previously was 1.1, and bilateral hydronephrosis with no obstruction or calculus on the workup.
So sorry, she is on intermittent catheterization at this point?
She doesn't do it because she's finding it very hard. She doesn't allow anybody to do it.
Sure.
So we proceeded to this.
Can we just go back one slide? A couple of points I wanted to make here.
Yeah.
I think it's important for us to understand that in the presence of pus cells in the urine or a positive culture is not the same as a urinary tract infection. So it's very important not to give antibiotics to somebody just because the urine shows pus cells or the culture grows something. The patient must have symptomatic infection or should show features of systemic infection, even if there are no local symptoms. So unless they have elevated blood counts or fever or low symptoms consistent with infection, we wouldn't treat it. Sorry, go ahead. Yeah.
She had fever, so she was treated with antibiotics and then sent by the GP.
Sure.
So this was the urodynamics.
Right. So is red which one is the detruser line? I'm not able to see it very clearly. Is the top line the detruser or the third line?
Third line.
The third line. Right. So as I can
one vesicle, third one detruser in between the abdomen.
Right. So the red one is detruser.
Yes.
Okay. So as I see here, I don't know what's the volume filled in?
Which one? The 20 to 30 ml per second.
No, the total volume that's been filled. 340.
Around 340, yes.
Okay, right. So what we see here is that as the bladder is being filled up, you can see the bladder pressures are progressively rising. So a normal bladder, when it's filled up, should not show much rise in pressure. It's like a soft balloon into which you're trying to blow air. So you expect the bladder pressures to be close to the baseline. So very minimal rises in pressure are expected in a normal bladder. So if it's not a flat line close to zero, it can take one of two forms. You could either get a progressive rise, which is the dominant finding here, which we call a poor compliance, which happens because of loss of elasticity of the bladder wall. Or you can get a phasic rise and fall, which we call detrusor overactivity, which is probably superimposed on this picture here. So the dominant finding here is poor compliance, perhaps with low pressure detrusor overactivity also. And assuming that her scale is is this scaled up to 100, this whole thing from top to bottom? Yes. So her storage pressures are going very high. You can see about 60 centimeters of water, I think, at end fill. And this is a recipe for getting into upper tract problems. So this patient has a poorly compliant bladder despite a capacity which looks okay.
Yes.
So capacity, again, an important lesson from this case, which is a good case to demonstrate this. Capacity is not the same as safety. So you could have a capacious bladder, which is unsafe because the pressures are going very high. So the safe capacity in this patient is barely 50 ml. Because beyond the first 50, 60 ml, the bladder pressures are already going into an unsafe zone. And over a long period of time, this would be inevitably damage the upper tracts. The other thing that we are seeing here is, I'm assuming at the end when the pressure's gone high that she's been told to void. I'm not very sure.
Yes, she's told to void. Okay. And she's saying she has to void, but not able to void.
Okay, so if the rise in pressures which has happened at the point of end fill is because of a volitional contraction. Oops, I'm so sorry. If the rise in pressure is because of a volitional contraction, then in that case, because she generated a high pressure contraction and she did not void, this implies bladder outlet obstruction. Now, if she does have, so I'm assuming that that she was told to void. The filling was stopped. She was given a command. She produced a volitional contraction, and she couldn't pass urine. So that is suggestive of bladder outlet obstruction. Now, if she has bladder outlet obstruction, this study seems to suggest as if it is a synergic obstruction. So if you get a bladder outlet obstruction, you can either have synergia of the striated sphincter or a dyssynergia of the striated sphincter. The EMG line seems to show some element of reduction in the activity during the attempted void, and it seems to be synergic from this. But having said that, the EMG is the least reliable part of a urodynamics test, and usually I would not place too much of reliance on the EMG in making a decision as to what the patient has. So from this study, normal capacity, poorly compliant bladder, unsafe end fill pressures with bladder outlet obstruction.
Okay. So do we really need EMG given that it's not infallible and it's not reliable? If so, what should we be doing?
So now in our studies these days, so I use an EMG more as a kind of a support, you can say. I also use an EMG as a part of the flow. So what we do is all our patients in whom we are using the EMG have a flow EMG at the end of the test where there are no tubes in the urethra. And the patient is passing urine into the uroflow meter with the EMG patch electrodes attached. And that EMG interpretation usually I find is more reliable because there's nothing in the urethra. They're not having any discomfort related to a tube. And if they show synergia there, then I would be more willing to accept that. But to be honest now, over the last year or so now, if we have any doubt that there's a problem with striated sphincter, so in this patient, for instance, who has a background of neurological problems, we would always combine it with imaging. So we would not rely on EMG to make a decision as to whether she has dyssynergia or not.
So would we do a video urodynamics? Is that what we're telling?
So these days I would always do a video urodynamics, but in case you don't have access to it, then combining it intuitively with a micturating cystourethrogram is reasonable. But ideally, the MCUG needs to be done as a cine MCUG record, capturing the entire voiding phase, or you need to be standing there to shoot at the right time and watching by fluoroscopy to decide when to shoot. Because if there is a dilated proximal urethra when the patient voids, which would be consistent with striated sphincter dyssynergia, you might not see it consistently throughout the voiding phase. So if you're imaging just relying on the radiologist or the technician to shoot in between and give you a couple of images of the voiding phase, you might actually end up missing a dyssynergia at that, because of that. So either you should have a full cine of loop of the entire voiding phase, or ideally you or one of your residents or somebody who understands the thing should be there to actually watch on fluoroscopy and shoot at the right time and make sure that you don't miss it.
Sure. So how would you get to this? Just by, I understand you said EMG with the Euroflow. Anything else on the Euroflow which will help us to understand that we are pointing towards the right diagnosis?
So, I mean, the Euroflow per se, I mean, the only reliable part of the Euroflow is it normal or abnormal? To be honest, most of the
considering a female pattern.
Yeah, so most of the other interpretations of the Euroflowmetry don't really stand up to scientific scrutiny. But having said that, let's say a patient has dyssynergia. That's one of the situations where you could get what's called a staccato flow, where the flow goes up and down rapidly. Now, remember, the bladder is a smooth muscle. A smooth muscle takes time to recruit. So when the bladder contracts and you get a flow because of a bladder contraction, it has to show a smooth pattern. So you can get ups and downs, but you can't get sharp ups and downs. So any sudden up and down stroke in the voiding, whatever you're getting on the flow rate, has to originate in a striated muscle, can't originate in a smooth muscle. So either it's got to be because the patient is straining with the abdomen in an acontractile detrusor, or it's got to be that the sphincter is overactive when the patient is passing urine and producing spikes. When the sphincter contracts, the flow drops. So sharp changes cannot happen because of a smooth muscle. But there's so many confounders to this. So if a patient is uncomfortable, they've got 10 people peering at them to see what's happening, the pain of the tubes, the embarrassment. I mean, all these things, the legs dangling in the air in a child because their feet don't touch the floor, all these things can actually mimic the same flow findings. So as I said, the flow pattern is not a very reliable indicator of what the underlying pathology is, but except to say whether it's normal or abnormal. But when we do find some of these things, we like to say, oh, you found this, and hence it really points to that. So we can use it as a support, but really not to make a diagnosis. Back to you. Can you hear me? Shailesh, can you hear me?
We can hear you, sir, but I think Meera has got disconnected.
Oh, okay. I was wondering whether I got disconnected or she got disconnected. Okay. So until she gets reconnected, I'll just keep the conversation rolling. These days, we always do a video study. And on a video study, you can see this very well. And you can demonstrate whether the patient has dyssynergia or not. So all our patients who are neurogenic, all our pediatric patients, all female voiding dysfunctions require imaging, because you can't really diagnose non-neurogenic female voiding dysfunction without imaging again. So all these patients have imaging combined. The only patients in whom we don't recommend imaging actually as a routine matter of routine is patients who have purely stress incontinence kind of presentations without much of a prolapse. Welcome back, Dr. Meera. You need to switch back your audio. Your audio is off.
You need to unmute.
Yeah, unmute yourself. Yeah. So we kept the conversation going.
Thank you. Suddenly lost connection.
No problem. That's okay. You can reconnect your slide. Okay. Yeah. So the only patients in whom we don't do a video these days are patients, let's say, for instance, elderly men with BPH kind of presentations, and women presenting with, say, plain stress incontinence, no major prolapse and things like that. All other patients, actually, we now offer a video study. We can get back to where we were.
Yeah. So this was the impression which was made, a neurogenic bladder with pelvic floor dyssynergia. We have to come to agreement on that. Right. Probably because of that leading to a secondary bladder outlet obstruction.
Now the thing is, this, if we look at the neurological lesion, the neurological lesion is not really consistent with the urodynamic findings. But we know that neurological lesions don't really show a good corroboration with the urodynamic findings. But here you can see the level of the lesion is lumbar canal stenosis, and lumbar canal stenosis should impact the cauda equina or the conus, because the cord ends at the initial part of the lumbar canal. So if the patient actually has a neurogenic dysfunction because of a lumbar canal stenosis, the classical feature would be a bladder that does not contract. So usually you'd expect an acontractile bladder rather than a bladder outlet obstruction. But as I said, sometimes you have skip lesions, you have other lesions, and sometimes you don't get a very good correlation. But this does not correlate. So if this patient, you said, had all other focused neurourological findings as normal, which is what you told me, then I would have some doubt in my mind whether the bladder problem is independent of the lumbar canal stenosis problem, especially if she does not have constipation. So if she has no constipation, focused neurourological exam normal, my first gut assessment would be, diagnosis would be that the voiding dysfunction is not neurological. So she has an independent lumbar canal stenosis, and she has a non-neurogenic voiding dysfunction. And we are back to the imaging, because without looking at the imaging now, it becomes difficult to identify. Now, if some things we can rule out. So does this patient have an anatomical obstruction? Very unlikely, because you put tubes in and you would have picked up an anatomical obstruction. So if she is obstructed, it's got to be some form of a functional obstruction, because there's no structural abnormality. And functional obstructions can only happen at primarily 3 levels in a woman. Either it's got to be at the bladder neck, or it's got to be at the striated sphincter or a pelvic floor, which is the same level, or she must have an extrinsic problem, like say a prolapse, which is causing a mechanical obstruction. She doesn't have the prolapse. So that leaves us only with the other two. Either it's a bladder neck, a primary bladder neck obstruction, or a striated sphincter pelvic floor dyssynergia kind of a picture. A primary bladder neck obstruction in a woman is a very uncommon diagnosis. So purely on the basis, and the kind of pressures you are seeing would be unlikely. So purely on clinical grounds, the kind of picture I am seeing, I would put my bets, let's say, on this patient having pelvic floor striated sphincter dyssynergia, not even pelvic floor, I'd call it a striated sphincter dyssynergia with the kind of pressures you are seeing with all secondary changes. So in a sense, this is manifesting like a neurogenic bladder. This is what you would get actually in a neurogenic detrusor sphincter dyssynergia. Whether we're able to pinpoint a neurological condition underlying it or not, I'm not very sure at this point. We need to search for it. But it's presenting exactly like a detrusor sphincter dyssynergia, high-risk disease, and upper tract changes with secondary problems during storage.
Which is very important while counseling the patient, because if she was to undergo a spinal surgery, thinking it should become better, I don't think we are giving her the right picture.
No, we are not. In fact, even if she had a problem related to the lumbar canal stenosis,
even then,
inevitably, once you get the urinary tract
pressure changes
problem, after you take care of the underlying pathology in the spine, that the bladder problem almost never recovers. It's very rare for it to actually improve.
Absolutely.
Some changes, a little bit of drop in voiding pressure and blah blah, I've seen in children with T3 cord. Sometimes it does happen. I'm not saying it doesn't, especially in children. But in this clinical picture, I'd say whatever the underlying pathology, even if you treat it, it's unlikely to go away.
Sure. So what will the plan? We did this severe trabeculation, saculations, ureteric orifices, seen 200 units of botulinum toxin at 30 different sites of the bladder cavity. This is what was done. Okay. Subsequently, what would we want to do?
So let's start.
Why do we think we need to follow this patient?
Let me start at before the botulinum toxin point. So the first step would be to decompress the bladder, because this patient has come again with an elevated creatinine of 1.7 and is not on CIC, from what you tell me. So I would put back a catheter in this patient, wait for 2-3 weeks, allow the creatinine to settle, and hopefully, if she's lucky, it comes back to normal. From that point now, I would actually first initiate conservative management. So aggressive management with anti-muscarinics. So this is not a place for using a beta-3 adrenergic agonist. We would use conventional anti-muscarinics, and probably you need to increase the dosage over a period of time. This compliance that you saw as a poor compliance may not be reflective of true fibrosis, not necessarily, because this patient has not had all appropriate therapy. It's possible once you actually put her on treatment and she's on regular CIC, you might see some improvement in that compliance. compliance. So anyway, I would put her on antimuscarinics, and I would teach her, explain to her that she must do her CIC properly. We would follow this patient with a CIC diary. All our patients need to come back with a noting in a notebook of the time at which they have removed urine and how much they have removed for a minimum of 1 day. If they don't come with that, I don't see them, they know it, and they'll always come with it. So even the illiterate patients are able to do it. Based on the CIC diary, I would decide whether to enhance the dosage of her medications, also see her compliance, her fluid balance, and so on. And if once I reach either a ceiling antimuscarinic dose, or if I reach a situation where the patient has become asymptomatic and the diary looks good, one of these two things will happen as I'm escalating the treatment. So either the diary will show that, okay, she's emptying her bladder 5 times a day, emptying about 350 ml, no leakages in between, no urgency in between, looks like the perfect situation. Either that will be there, or she keeps leaking in between or requiring multiple catheterizations and can't manage at 5, despite having escalated to the peak dose. One of these two has to become an endpoint. And at that endpoint, I would repeat a urodynamics on medication to see what's the situation. So it's possible that she seems good on the CIC diary, but on a repeat urodynamics or on medication, we find that the pressures are still unsafe. Because here, once it's a safety issue, symptoms are not the key. In a safety situation, the pressures are the key. So even if the patient appears to be very continent, is perfectly fine, that's not good enough. And remember, putting the patient on CIC doesn't sort out the bladder. CIC only takes care of the 10 minutes of voiding, as we discussed. The rest of the 23 hours and 50 minutes needs to be managed separately, because otherwise, despite the CIC, patient will knock off the kidneys. So on medication, let's say I repeat the test and I find that the patient still has bad storage pressures. Now, if I've reached the ceiling dose, there are only 2 or 3 options for us. For a poorly compliant bladder, so that the logical next step is typically botulinum, which is what you have chosen for this patient. The problem with botulinum is that predominant poor compliance doesn't respond well to botulinum. So botulinum has been shown to work well with neurogenic or non-neurogenic detrusor overactivity or idiopathic overactive bladder. But if the patient has poor compliance, doesn't seem to work. Now, if you look at the initial studies on the basis of which botulinum was approved for neurogenic bladder patients, these were primarily spinal cord injury and multiple sclerosis patients. And across 2 large studies, I did a search for poor compliance, and not a single patient was reported to have poor compliance. I was a little unbelieving, so I actually did compliance, put COMPL, and I actually searched through both the articles. Have I missed it somewhere? And it was just not there. The word didn't figure in their recruitment material and methods anywhere. So it appears that they could recruit more than 600 patients across 2 studies with no poor compliance at all, or they just didn't choose to record it. I'm not very sure what happened, because in our experience, when we do urodynamics for our patients, a significant number of patients show poor compliance, probably because treatment is not initiated at the onset. So if you initiate treatment early, you can prevent poor compliance. But if patients are late, poor compliance invariably happens as a consequence, and it's difficult to treat. So I would inject botulinum if even if she's got poor compliance, but my counseling would be very different. Very different. Unlikely to respond. And on botulinum, I would recheck her pressures to see after, let's say, about 8 weeks or 12 weeks to see how well she's actually responded. Again, not just on the symptoms, but also on the pressures. And if she's fortunate and responds well, then we could continue re-injecting the botulinum. Otherwise, in this patient, if the creatinine comes down to normal, I would have a low threshold for planning an augmentation cystoplasty in her.
Okay, in spite of the capacity being normal?
In spite of the capacity being normal. So our recent report paper, which has just got accepted in the Asian Journal of Urology, which is on children, but you can draw parallels from that. These are 13 children who presented with chronic kidney stage 4 with a neurogenic bladder, because of it, secondary to a neurogenic bladder with CKD4. And there are 13 children which we've augmented during my career. And of these 13 children, 3 of the children had perfectly normal bladder capacities, but very high storage pressures despite that, just like your patient has. So despite the apparent good capacity, she would still require an augment. And very often you don't need a very large augmenting segment. You can manage with a relatively shorter segment, but it still needs to be adequate, because the last thing you want is to under augment and land up again with a patient who still has uncontrolled pressures.
Okay. Now, this is what happened post-operatively. She continued to have the CISC, pelvic floor relaxation exercises with biofeedback considering the dyssynergia, antispasmodic for the pain and the anticholinergic agent, and a low dose, long-term prophylactic antibiotics because 2 episodes of fever had set in.
Prophylaxis is not recommended in patients on CIC for the simple reason that you can't sterilize the urine when you're using a tube, and you're likely to breed resistant bacteria. Now, the fact is, so a short-term prophylaxis, if she was getting into sepsis until you sort it out, is fine. And the reason, I mean, if any patient is getting into, so some episodes of urinary tract infection in patients on CIC is expected. So 1 or 2 urinary tract infection episodes, 1 episode in a year is probably par for the course. But if she was getting into sepsis state or multiple infections, that suggests there's a problem with some point of the management. So if the management is correct in terms of the storage pressures, in terms of the CIC compliance, everything is taken care of, you don't expect repeated UTIs. So especially if and remember, UTI is a clinical diagnosis in a patient on intermittent catheterization, never a microbiological diagnosis. So if the patient is getting clinical infections, then it suggests that you need to go back to the drawing board and check what's wrong with the management.
Sure. Dr. Sailesh Raina, would you ask any questions to Dr. Sanjay Sinha based on this? How do we take this patient any further?
Good to see you, Shailesh. So Shailesh was part of our urinary incontinence guidelines panel. This urinary incontinence guidelines panel of the Urological Society of India was for non-neurogenic urinary incontinence. It was a 2.5-year project which we published in 2019, and I'm happy to tell you that he was one of our co-authors. Shailesh, go ahead. Your mic is mute.
Right. Can you hear me now? Yeah. No, I think you summed it up very nicely, Sanjay. The only thing is, how long would you wait before you do an augmentation on these bladders? That's my first question. And secondly, there's no doubt that for children, we need to do it on the video and a sign, and for neuropathic bladder. Now, you're calling this a neuropathic bladder. Am I right?
So all I'm saying,
you're calling this a bladder. You're calling this a detrusor sphincter dyssynergia.
Right. So
yes.
It's a question.
Now, most detrusor sphincter dyssynergias, that word, would be talking in terms of a neurogenic or a neuropathic element in it.
True.
So how long would you, now with this capacity of 340, high pressures, she's given botulinum toxin. Would you like to give more botulinum toxin and continue with CIC for some time before an augmentation, or would you straight away go for an augmentation?
Okay, all good questions. So because this patient has presented primarily with poor compliance and has already demonstrated that the lower tract is unsafe, because she originally presented with renal failure and has repeatedly come back in renal failure. So she's a high risk situation, and sometimes even 6 months or 1 year of delay is enough to push them into long-term chronic kidney disease and a cycle of getting into end-stage kidney failure over the next few years. So all such patients, I would sort out early. So when I say early, if you're injecting, if I'm going on to whatever I have to do, I'll be doing rapidly. So if I inject botulinum, then over the next 8 to 12 weeks following botulinum, I would check and see what happens. And unless there's a dramatic fall in pressure, I wouldn't rely on increasing the dosage the next time round, because I don't think that going from 200 to 300 is going to dramatically alter things. In my experience, it's more often that you increase the duration rather than reduce the pressures further. So of the response. So I would see the pressures, and if the pressures continue to be high, I wouldn't wait for her to again develop hydronephrosis and so on. I would actually straight away counsel them regarding augmentation. But remember, any patient getting augmentation must demonstrate compliance with CIC. Now, this patient to start with did not demonstrate compliance with CIC. If you augment the bladder, and if she doesn't do CIC for 1 day, you may kill her.
Correct. Right? That is the problem with her.
Right. So she has to demonstrate that she will do CIC. If she doesn't, you cannot augment such a patient. Now, the other question was related to the terminology, and I'm glad that Shailesh actually brought it up, because I must clarify this. No, if you have dyssynergia of the striated sphincter or pelvic floor, and I'm using the word "or" very deliberately because none of the current technologies that we use can reliably differentiate these two conditions. Whether it's a video study, whether it's a UPP, whatever you may do, none of these will actually differentiate between whether the dyssynergia is at the level of the pelvic floor or is at the level of the striated sphincter, because they're anatomically at the same point. Now, where was I? Yeah. So if you have dyssynergia of this at this zone, This dyssynergia can happen in the presence or in the absence of an underlying neurological condition. If you have an underlying neurological condition, we term it on the basis of ICS International Continence Society terminologies as detrusor sphincter dyssynergia. Now, if there is no underlying neurological condition, the ICS says give it the label of dysfunctional void. But the ICS also says that such patients have a fluctuating flow. Such patients have demonstrated that it's a learned behavior, and these are missing in many of our patients. There is no ICS terminology, International Continence Society terminology provided for a patient who is like this. The kind of patient that we have shown, this patient does not have an underlying neurological problem. Generally, with a dysfunctional void, you don't expect very high voiding thresholds, right?
No, you don't.
We don't.
You don't. So, but in any case, so I would treat this as a neurogenic dysfunction. Keep searching to see if there's some reason to explain it. I would be a little skeptical whether the lumbar canal stenosis causes this, and that's where we stand. But I'd manage her just like a neurogenic dysfunction.
Dr. Vijayalakshmi, you wanted to ask a question, ma'am.
Your mic is muted.
There's a lot of disturbance.
Sir,
Can people mute their microphones?
So just one very basic question, because I'm a gynecologist.
No, go
I'm
ahead.
not into lots
The
of these
basic
things
ones are the
which you
most
said.
important ones.
Yeah. No, actually, I have a patient who had Guillain-Barré syndrome, and she did recover from everything else except the bladder issues, and she's on intermittent catheterization and all those things. But obviously, she gets fed up and get in between, and then she just pulls it off, and she says no more catheter. So, do I think that she'll be benefited by whatever you have discussed with the Botox and augmentation or whatever?
Okay, so patients who have would
you call this as a neuropathic or neurogenic or whatever?
Okay, so if she's got an underlying neurological condition which can explain the voiding dysfunction, then we would label it as a neurogenic bladder. And all neurogenic bladder patients, especially if they are not responsive, then you need to do this kind of a patient, not all, I shouldn't say all, but this patient, if having voiding dysfunction, catheterized catheter, needs a urodynamics, not just to check whether CIC is required or whether we can do something else, to also see whether CIC is enough based on our previous discussion. Now, if this patient has an acontractile detrusor, then acontractile detrusors can happen so acontractile detrusor means that when the patient tries to void, the bladder doesn't contract. And assuming that this is not an artifact. So let's say, for instance, you're doing my urodynamics that I don't like your face or whatever. I mean, I don't mean it literally. I might decide not to cooperate in the test and you might get an acontractility. So let's say we've taken care of all I'm very shy and I've got 20 people looking at me when I'm doing the test. Let's say all those things are taken care of and the patient truly has an acontractile bladder. Acontractility, we don't understand very well where all it might originate. But if the last neural arc is intact, then there is a reasonable position in such a patient to try sacral neuromodulation. So sacral neuromodulation by and large is not meant classically for neurogenic patients. It's not. Right now, guideline recommendations are not for the neurogenic patients. But in a patient like the kind you are talking about, in this kind of a patient, it might not be end organ problem. And in such a patient, if the last neural arcs are intact, it might make sense to try and see what happens. And if that might be one thing that might help. There are small series on other things like latissimus dorsi flap and so on. Dr. Shailesh has some experience with that. But by and large, otherwise, most such patients do require intermittent self-catheterization. And I would say that 99% of patients are happy doing it because it improves their quality of life. The patient's acceptance of CIC is completely dependent on your being convinced about it. By your, I mean the doctor, not the patient.
Thank you.
Thank you very much. Thank you very much, sir. Thank you.
My pleasure. Thank you.
Thanks, Sanjay.
Thank you. Thanks, Shailesh. Good to see you.
A pleasure.
Okay. Yeah. Moving on to the next case, I would like to invite upon Dr. Tamil Selvi, my dear friend, and are we able to see the screen?
Yes, Meera.
Thank you. 48-year-old obese female presenting with complaints of severe urgency, urge urinary incontinence with stress incontinence, worsening over last 4 months, increased frequency of urination, nocturia, no symptoms of dysuria and fever, history of ongoing treatment for anxiety disorder, 4 cups of tea or coffee per day. So this is a medical history. So what are the pointers on the urogynec history, and why do we need a detailed medical history for such a scenario?
Well, as Dr. Sanjay Sinha was elaborating, the time you spend on history is what is going to give you a lot of information. So the history, basically, you're looking at what is happening in the storage phase, what is happening in the voiding phase, and has to, during the storage phase, you've told me she's got urgency, urge incontinence, and she's got stress urinary incontinence. And I haven't got any information regarding the voiding symptoms, what she's got, whether she's got any difficulty in hesitancy or emptying, the stream is good, whether there is sensation of incomplete emptying.
None.
No, none. Okay. So the medical history. So when it comes to bladder, I always say you have to go back to your medical school days. Start from each and every information from that patient is important. And it comes to basically from the obstetric gynec history and the medical history, medications, what she's on, what is her problem. Now, the importance of medical history is what we have been discussing so long. Whether we need to rule out whether it is an idiopathic overactive bladder, means an overactive bladder which is not neurogenic, or whether there is an element of neurogenic, whether there are precipitating and aggravating factors which could be contributing, such as a diabetic patient, a poorly controlled diabetic patient, or a patient with polydipsia, idiopathic polydipsia. And in our case, this patient has got hypertension, and what are the medications she's on? Is she taking drugs which can increase the urine output, and she's taking it during the daytime? That is important. And if it is a diabetic patient, it is a poorly controlled diabetes, that sort of information is very important from the medical history.
Okay.
And also when it comes to medical history, also the problems, what are not only medical problems, when I'm talking about medical history, I'm also have to include the surgical problems. If she's had any back problems, back surgeries, any spinal cord trauma, any surgeries in the past, pelvic surgeries, all of that is going to be contributed. When we say medical history, we're just not talking about hypertension, diabetes, and thyroid. We are also looking at pelvic floor and back surgeries and back injuries. Those are the things we are looking at.
Thank you. So this is her pelvic examination finding. The external genitalia, the urethra, bladder, vagina normal, no stress leakage, perineal sensation reflexes were preserved, no prolapse, and good Kegel pelvic floor muscle contraction was elicited. And the urine analysis were normal, no significant postvoidal residue, and the uroflowmetry was good with a Qmax of 20 ml per second. This is just to give you an idea of her bladder diary, which she has sent pages of. So,
Meera, I'm not actually able to see much. Can you tell me the frequency? Is it every half an hour I'm seeing, or is it
pretty
every
much,
1 hour I'm seeing?
pretty much every half an hour. Okay. And volumes of 100, maximum ranging to 200 occasionally, pretty much rounded off to 100, 150, and the leakage is small to medium.
Okay.
And
how much is she drinking? What is she drinking? How much is she drinking? I'm not able to see that.
That is not very clearly mentioned. So it's more of a frequency volume chart rather than a proper bladder diary. Which is why I would want you to explain the difference between a frequency volume chart and a bladder diary for the benefit of everybody.
So frequency volume chart basically will tell us how much the patient is voiding, at what time she is voiding. So it will give us an idea of the history correlating with the symptomatology. But as to find out whether there is a reason for what she's doing, then we need a bladder diary. For that, we need to know what she's drinking and how much she's drinking. So in a patient, you've already said she's addicted to caffeine. And if she's drinking 4 to 5 cups of coffee, and she's drinking about 5 liters of water per day, and she's sitting in an air-conditioned room and working, then all the more reason for her to have a frequency. So that is important. And in the bladder diary, it is also important for the patient to mention if she's having a leak or not, and if so, what makes her leak? What was she doing when she actually had the leak? So that information will also be contributing to the bladder diary completeness.
Thank you. So in case of overactive bladder, what important aspects should you concentrate on urine analysis, uroflow and imaging, and why so?
Okay. Urine analysis, as we said, urine analysis will give us an idea whether this patient has got a poorly controlled diabetes or this patient has got pustules with symptomatology. So if she's got dysuria and if she's got burning sensation with severe pustules, and also whether she's got microscopic hematuria. So whether there is a intravesical pathology that can be identified by a microscopic hematuria, or if the patient has got a urinary tract infection, then we proceed from the urine analysis to a urine culture. Sometimes this is the only test which helps us to diagnose a patient who has not been diagnosed with diabetes, because sometimes they come and have a urine analysis and they have 4+ of glucose, and we never know that patient has not known that she was a diabetic in the first place. And uroflow basically will, the urine analysis will also help us to cater to something called whether this patient is at a high risk, or this is more to do with history, whether the patient is at a high risk of with microscopic hematuria, with no pyuria and no evidence of infection, whether there is anything going on in terms of a growth inside the bladder, and that will point us towards a urine cytology as well. Coming to uroflow, normally I wouldn't do uroflow in a patient who presents with urgency, urge incontinence, but a uroflow in this patient can tell us if the post-void residual urine is measured. The post-void urine measurement along with a normal flow pattern can give us an idea what is happening to the bladder storage function and whether the voiding is incomplete or complete. Imaging again can serve the same purpose. Imaging in terms of checking the lower tract for post-void residual and the upper tract to make sure there is no upper tract dilatation can help us to identify what is the possible pathogenesis for the symptoms what she's got.
So what do we make of this woman as an impression, as a working diagnosis? Say in the COVID era, this was a teleconsultation and we haven't had the benefit of seeing the patient in person.
Okay, a clinical diagnosis, even in the non-COVID era, we would have pretty much the similar information what you have given.
Absolutely.
So what we are thinking of a predominant overactive bladder with stress mixed incontinence, basically a predominant overactive bladder component with stress urinary incontinence. At this point, it is important to identify from the patient herself what is the troublesome symptom for her. Is it the fact that she's not able to control and rush to the toilet? Is it the fact that she's leaking when she coughs or sneezes? So the predominant symptom has to be ascertained, and what is the quality of life. So, and once we have established what is the predominant symptom, yes, the conservative management forms the main role in both SUI as well as overactive bladder. So we start off with conservative measures. And for SUI, we'll start off with pelvic floor muscle training. And for the overactive bladder, the first and foremost in this patient will be to identify the amount and type of fluid and ask her to regulate that. So written instruction has to avoiding caffeine-related drinks and also to identify how much of fluid. So she might need about 2 to 2.5 liters, sometimes 3 liters. But if she's drinking 5 liters, then yes, definitely that needs to cut down. And reducing the use of aerated drinks. A lot of these patients are addicted to aerated drinks. So that needs to be ascertained from the history and reduced. Once we have established that rule for the patient, then we move on to the anticholinergic. And here, when I say we move on, we are not going to send the patient away with just bladder training and pelvic floor exercises and ask her to come for anticholinergic, because our patients definitely will need some medication before they leave the clinic. And also it is important for them to gain the trust that we are treating them. So the first choice of medication is anticholinergic. And anticholinergic at this point would be, she's 48-year-old. It's based on the side effect profile also. What is anti-anxiety drug she's taking? By the way,
she's only on
any idea?
escitalopram.
What was it?
Only escitalopram.
Anti-anxiety drug.
Only,
yeah. So yeah, so that has got a, yeah, that is definitely has got an effect on the bladder. So the anti-anxiety, the important thing is when you say that to a patient, the patient might stop. So it is important not to actually say it in so many words, but also tell them you need to continue the medication and we are going to give you additional medication to help with your bladder. So you need to understand, we need to understand there is a medication which needs to be continued and we need to add something more onto that. So the first choice of medication will be anticholinergic. Now, from 2000, from the time I started my clinical fellowship in urogynecology in the UK, and for the last 20 years, I've come through these phases of medications. So we started off with oxybutynin, then we moved on to tolterodine, and then we had trospium, and now solifenacin, darifenacin. So currently, it is mainly, and we all need to know the red alert messages, almost all of them will have the similar efficacy. It is a side effect profile which determines whether the patient continues the medication or not. So for that reason, I would choose a medication where the side effect profile is actually lower for the patient. For that reason, a solifenacin drug might be the first drug of choice where the side effect profile is lower. So when I say side effect, it is not just a side effect of allergic or anything like that. The dry mouth is very, very troublesome to patients. The patients do not take medication because of the dry mouth. Constipation. Dry mouth constipation is a reason why they actually discontinue the medication. So a solifenacin drug would be the drug of choice at this point. And one important thing I would talk about medication at this point is there is no point in continuing the medication if the patient is not showing any benefit. So give it a choice of about 12 weeks or 3 months, and then consider whether you need to add on a medication, because there is no point in just increasing the dose. If you keep increasing the dose, only the side effect will increase. The efficacy will not increase. If it is not working, it is not working. So you need to look at combination therapy. And when it comes to combination therapy, that is where the mirabegron scores now for us. So mirabegron actually is the side effect profile of mirabegron is not anticholinergic. So it is basically a beta adrenergic agonist. So the dry mouth constipation effect is not there. So the compliance will be better for the patient. Now, at this point, I'm coming to your next question. I think we have discussed all about the medication.
Absolutely.
When we come to invasive testing, would I consider invasive testing not as a primary one, but if the patient is not responding to 1 or 2 drugs and the patient is regularly taking the medication, the complaints has to be addressed, and we have a frequency volume chart or a bladder diary which shows us that it is not working. Yes, then we have to look at whether we need to identify whether there is a urogenic element. Is there a voiding problem? What is the reason she is not actually progressing towards the treatment goal? Then at that point, the invasive testing will be a urodynamics. Yes, cystoscopy also will be considered, provided there is a reason for the cystoscopy, such as I find a sterile pyuria. I find that the patient has got microscopic hematuria. Then I would consider going for a cystoscopy. Or on urodynamics, I find that this patient has got basically low compliance bladder and basically is increasing, whether there is a neurogenic element. I want to know whether there is a trabeculation inside the bladder, what is going on. So I need to know what exactly is going on with that patient. What is that supposed to be? Assessment, she's got overactive bladder, she's got hypertension.
This is the next slide. That is my assessment. So what if the medical management fails here? So we've done all what you have said, 1 to 2 drugs combination, 8 to 10 weeks we've done. Still overactive bladder.
Right. Now time to move on to the second line therapy. Now time to move on to second line therapy is easy for us to say. Now when we move on to the second line therapy, then we are looking at Botox injections. So botulinum toxin is what we are looking at a second line therapy. Now, the important things before we plan a Botox for the patient is basically to identify whether the patient has got a normal bladder capacity, what is a post-void residual, whether she is willing to do a intermittent self-catheterization. So all those parameters have to be identified. So this is the urodynamic picture of this patient.
After all this, discussed, all this was done.
All this was done. Okay.
Then subsequently,
then because she was not responding, you did a urodynamics. Okay. And on the urodynamics, you're having detrusor contractility. What is the volume at which she's got detrusor contraction? A capacity is 310 ml. Is it phasic detrusor? The last one is the detrusor contraction. Is that correct?
Yes.
The last line is the detrusor contraction. Okay, fine. Okay, so she's got phasic detrusor contraction. And does she empty with the detrusor contraction? Does she have a leak? Did she have a leak? Because I was not able. So she has. Okay, so she's got urgency, urge incontinence. Yes. and she's not responded to anticholinergic. Yes, then at this point, we need to go ahead with the second line of therapy. So we need to identify what is the second line of therapy. And in this patient, we need to think of using a Botox injection. This is only after trying the anticholinergics to the maximum benefit to see whether the patient is responding to the anticholinergic or not. Only after that, we offer a Botox injection.
Okay. So this is what was done. How to follow up this patient?
Follow-up of this patient now, even before I offer the Botox injection to this patient, what is important is to tell this patient this is a recurring treatment. This is not a one-off treatment, because the minute a patient goes into a theater, they assume that is the be-all and end-all and that is the treatment for them. So it is important to tell them it's a recurring treatment, and also to tell them that they need to actually be initially for the first couple of weeks, they will be on anticholinergics, and after that, they probably will not need the anticholinergics. But then the cost effective analysis, if you look at it, then if you are able to repeat it over a period of, sometimes it is up to 12 months, but more realistically, it is around 8 to 9 months is the time it lasts. And then you need to actually tell the patient that they need to come back. So follow-up of this patient basically is to identify whether she needs anticholinergics post-operatively I shouldn't call it post-operatively, post-Botox injection for a short time, and then follow this patient up to identify a time frame when she develops symptoms for a repeat injection. And also she should be willing for intermittent self-catheterization in case if the post-void residual becomes high. Now that post-void residual, after we moved over to 100 international units, the reduction in the post-void residual urine volume is low, and also we have not much worried about post-void residual for these patients, because the post-void residual now we know is not causing upper tract problems nor causing high levels of urinary tract infection. So the post-void residual is more to identify if it is significantly high, the patient should be willing to do intermittent self-catheterization.
Gopinath sir, would you like to ask Dr. Tamar any questions pertaining to this particular case study? Dr. Sailesh Raina, anything pertaining to this? And Dr. Vijayalakshmi ma'am? Ma'am, unmute.
No, in this highly specialized forum, I'm asking a very basic question, because a patient says that if it's related to diet as well, early overactive bladder, or what you can say a very mild overactive bladder, because most of the times she's inhibited whenever she goes out, she's scared that she will pass urine or leak urine. So at home she's comfortable. What she was saying was, when she eats particular dietary things, is it because I saw in your long list caffeine and alcohol, that all we know, but whether something bread and noodles and some gluten association, and that's what in fact Dukesh was asking. So do you really think there is an association with these dietary things?
There is no evidence to show that there is a particular solid type of diet, a gluten-free diet, will improve overactive bladder symptoms, madam.
No, not improve. In fact, she said she becomes, she's having more symptoms when she's eating those.
Eating them. So by avoiding those, symptoms might not get. So what we need to look at is the association of a fluid intake associated with that particular food she's taking. So it's usually better for, it is this group of patient where
even
the bladder chart will be very,
barley and all
so what they do is they actually develop a habit where they feel that if they empty completely, then they will get better. So they drink a lot of diuretics. So they take a lot of tender coconut water, they take a lot of barley water, which are all diuretic, and they actually worsen the symptoms. So it's important to identify. That is why the bladder diary is very important, to identify the type of fluid what she's taking and the amount of fluid she's taking. So then we will be able to convince her it is this fluid which is causing the problem, not the diet what you're taking.
Thank you.
Absolutely. Dr. Tamar, take home messages pertaining to overactive bladder for everybody.
Yeah, pertaining to overactive bladder, first take home message is a proper, thorough history, a medical school history starting from the basics is very, very important. That is the first thing. With relation to all the drugs what the patient is taking, not leaving out anything. So if the patient sometimes will feel, I'm taking for something for hypertension, I'm taking for anxiety, why should I tell you I've come only for urinary problem? So we need to actually elicit that history. That is the first part. Second one is treatment wise, a motivation of the patient is very, very important to give them the confidence that they will have some side effect, but they will get better, and they should not expect improvement within 2 days. It will take at least 2 to 3 weeks for them to notice an improvement, and that is very important. And addressing their quality of life. What is it they expect? What is it they expect to achieve? The third thing is they expect that they are able to go out without wearing a pad. They expect to go out actually to a temple and sit for 2 to 3 hours. That is their expectation. And if that goal is achieved, that is what we should aim at. So treatment according to the patient expectations, side effect profile, and how it's affecting their comorbid conditions.
Thank you very much. Thank you, Dr. Tamil.
Thank you. Thank you, Meera.
Thank you. I now invite upon Dr. Shrikala Prasad for the next domain in urogyne. Welcome, ma'am. So this is about childbirth and pelvic floor injury. This patient is a 32-year-old woman, para 1, forceps delivery, 1-year-old child presenting with complaints of fecal incontinence after delivery. Symptoms got worsened since 3 months, which affected her social life and a routine as well. The only significant points are history of seizures in childhood and a facial reconstruction with a gluteal flap because of some deformity in her jaw, and currently not on any medication. To Shrikala ma'am.
Yes, ma'am.
Yes. So the incidence of obstetric sphincter injury following normal delivery and instrumental delivery, because she's had a forceps.
Yes.
So and a fecal incontinence.
Definitely the incidence of anal sphincter injuries is much more in instrumental delivery versus the vaginal normal spontaneous vaginal delivery. But what is more important is the underreporting. Many of the times they don't really assess the degree of injury. So that is why we always put that one finger, that one finger, and say after every vaginal delivery, you examine properly. Do a vaginal examination, not only look for bleeding, remove clots, and also do a rectal examination and assess the degree of the perineal tear. That is very, very important.
So if somebody has to sustain say this lady, prototype patient, has had a OSS in this delivery, what is the incidence and recurrence risk in a subsequent delivery? Because if somebody has a normal delivery, they would say, why not have a normal delivery yet again?
Yes, true. So if you go through the literature and see the number of percentage of people who have undergone OSS, who had a sphincter injury, and how do they present in subsequent deliveries, if you go through Rani Thakkar, Abdul Sultan's paper, a vast majority have undergone cesarean section, normal deliveries. They have led them through normal deliveries, and only very less percent, like 7%, etc., goes in for a repeat OSS. Otherwise, by and large, they would be able to deliver without a repeat sphincteric injury. But only thing is, these patients should not be taken easily. They have to be really taken with care and monitored. And nowadays we try to restrict the episiotomy. It is not a liberal episiotomy. We give a restricted episiotomy. Earlier, like when we were postgraduates and all, we were taught once a previous rectovaginal fistula, we used to call it RVF, and it means that we will definitely take them up for a C-section during the next delivery. But now, if we are able to give them adequate care, we can deliver them safely. But only thing is, we need to counsel them. We need to find out how their, what is, the usual factors, not only the sphincter, we also need to know how is the presenting baby weight, size of presentation, all those factors. So these patients need to be really worked up carefully, counseled adequately, and then told that there is a definite possibility of a vaginal delivery. But by and large, if we see these patients, they are really worried because they really so much of hazard, they have so much of difficulty they have. They always ask for a repeat elective section. But if you ask me, yes, you can let them for a careful vaginal delivery. It is possible.
So what could they be presenting with? I know this patient presented with fecal incontinence. Do they always present like that, or anything else could be a
See, they
possibility?
can present with fecal incontinence, they can present with fecal urgency, they can present with flatus incontinence also. All these can be either to flatus, solid or liquid stool or gas. That could be their presenting features.
Ma'am, could you detail the systematic examination while examining a patient, say 3 months post-delivery? How would you assess them?
Sure. So I would, if it is, see, if it was at the time of delivery and I'm suspecting a sphincteric injury, then I would say I'll shift her to the theater under anesthesia and a good lighting with adequate lubrication. I will examine her first. That would be if it is immediately after delivery. Now you are asking me, now she's come back after 3 months. So now again, I will do an examination. I will assess with the good lubrication. I would assess, I will grade what kind of injury is. Is it a complete tear? That is, we grade it as 1, 2, 3, and 4. Obviously, if it is OSS, it is either 3 or 4. So I want to know whether the anal mucosa is also gone and how much of sphincter has gone. It's totally gone and gaping. I will completely evaluate and examine and then assess the patient and take him up for surgery.
So this is what was done. There was poor pelvic tone, no organ prolapse, and defect presenting at the posterior fornix, as well as not posterior fornix, posterior fossé at 4 o'clock to 6 o'clock position. And with the rectal examination and the pill rolling technique, showed poor thickness at the perineum and anal sphincter defect noted at 12 to 3 o'clock position. So this was what was noted. So what investigations are we going to do for this patient?
Normally, we don't do any investigations. We don't take them up for any anal manometry or, defecography and all that. Is a clinical diagnosis. By and large, we don't take up them for any investigation.
Okay.
If we also don't
find
do.
This patient had an anal defect, sphincter defect. Suppose we did not find an anatomical defect. Would you then go ahead with an anal manometry?
If there was no defect, if I found the sphincter, there's no anatomical defect, and then still she's having incontinence, then yes, I would think in terms of anal manometry, whether again a neurogenic effect is there.
Yeah.
Definitely.
The reason is because it's a forceps delivery. Yes. That is the reason I'm asking. What would be the implication if there was no anatomical defect, but yet the squeak pressure was not good? Where will that point us to?
It would be very difficult, because if there is a defect, then we can suture. But if there is absolutely no defect, then it is little difficult for us to, she may need to undergo other things also.
So this could be not a sphincter defect, it could be a neurogenic problem. Is that what we're telling?
Yes.
So repair will not help her.
True.
So if repair was not on cards for this patient, is there anything else we could think of for the fecal incontinence? Because this is a nightmare situation for this lady. She's very young. She's got a breastfeeding baby. She's only 3 months postpartum. And this is really troubling her day-to-day routine. So anything else which we could offer?
I mean, we can refer her to Shailesh Raina, who can do a lot of sacral neuromodulation.
Absolutely.
We have not been doing, I have no experience in that, and I have not done that.
So we
believe it's an anatomy.
Absolutely, ma'am. Absolutely. We should be thinking of the sacral neural modulation if there is no anatomical defect and the patient is as symptomatic as this. So this is the rectal sonogram which we did, the endoanal ultrasound showing the defect, typically where the clinical presentation also showed between the 12 and the 3 o'clock position at the level of the upper anal canal. And mid-canal, the intersphincter is thinned, and lower canal, again, defect in the external anal sphincter. A good chunk, a full quadrant thickness has been lost.
Yeah.
So this is
we can attempt to repair. This we can definitely attempt to repair. But only thing is sometimes to locate the internal anal sphincter and take the mattress suture is very difficult, especially, when we're seeing it after 3 months, we hardly see anything. So it's very difficult, but we can definitely try. suturing the internal anal sphincter and the external anal sphincter separately.
This is again, we proceeded to do the anal manometry as well. On attempted squeeze, inadequate increase, and she was able to expel. So definitely considering this, we made the diagnosis of an anal sphincter defect, which was post a sequence to the forceps delivery. So what would you do, madam?
I would take her up for a repair in the theater under good anesthesia. We would try to do a layered repair, try and reflect the from the anal mucosa. We will start. I will try to separate and try to, most of these patients, the external anal sphincter, we have seen it being really separated far away. We have to try and dissect and then catch it with our alley. And most of the time, it is really not possible to do an overlapping. Or at the most, we will be able to do an opposing sphincteroplasty. Very only in the fresh cases, at least I find it is possible to do an overlapping sphincter repair. But in these kind of patients, at the most, we will be able to do an opposing sphincteroplasty. If we are able to catch a good chunk of the sphincter and oppose, we can do it. We can do it either with a 3-0 Vicryl or a 3-0 PDS, but no figure of 8 sutures. A mattress suture is more than enough.
What will be the immediate post-operative care you would give this patient, and how will we follow up this patient after the
yes. These patients require lactulose and stool softeners so that a hard motion does not come and damage the repaired area, and good pain relief is essential. And we need to, what earlier we were saying that, we will not give anything by mouth for at least 5 days, then start for liquid diet and then go on. Now we are slowly coming up the other side, that we can start them with oral like we do for other surgeries. But only thing is, we have to be careful that, they don't pass a hard motion. So lactulose from the day one itself, along with good pain relief. And not only that, she has to be, after the repair also, you need to do a rectal examination. So remember that finger, we have to do a rectal examination to see whether our suture is proper. And then good antibiotic cover, good intake of fluids, lactulose, pain relief. Pain relief is very important. You need to ambulate them, and we need to see them review in a dedicated perineal clinic. And then later on, when all the pain is gone, we can teach them pelvic floor muscle training also.
Say she wants to opt for another pregnancy because this is only one single child now. What are the factors which will help you make the decision regarding mode of delivery, unless she doesn't deliver somewhere else? So
now she has had only it's a 1-year-old baby, and she has had a repair just now. I would like her to space for at least another 1 or 2 years. I would like her to conceive. I would allow her to deliver. But see, earlier we were saying an RVF go for cesarean section, and this patient, I believe in giving a mediolateral episiotomy. If I think that the perineum is little rigid and, it will cause more damage, but the many people are against a routine or a liberal episiotomy, an indicated episiotomy, but a mediolateral episiotomy at, the 60-degree at crowning is very useful. A very careful and dedicated support at delivery would help her prevent another oasis in this pregnancy. Though I would not straight away take her for section. I would be mentally prepared in case there is any obstruction. I don't want a big baby coming down and, having problem. Though all of them say that you can 7%. I do not want to be in that 7% and get into trouble. So I will be there carefully along with the patient, monitor her and take her through delivery safely. I may the increased chances of giving a mediolateral episiotomy rather than avoiding, and deliver her safely.
Let me rephrase the question, ma'am. Like forceps delivery, is this an indication for an episiotomy in subsequent delivery?
See, if you, I don't want another, havoc of undergoing an repeat RVF. But I would, honestly speaking, if you ask me, rather than textbooks, if I'm having a previous OAC patient in labor, delivering her vaginally itself is great for me. You know, my heart will be here. And then if I have to say, no, I will not give a medial lateral episiotomy, I think I will give.
Okay, agreed.
Honestly speaking, I'll give.
The evidence also suggests, the latest evidence, that there is definitely a reduction in the number of third-degree tears if they resorted to episiotomy, according to the latest ones. So, which is against what it was before. So they said episiotomy did not prevent third-degree tears, but now the trend towards that is increasing, just like the peritoneal closure. So maybe we should consider that. Are there any measures antenatally and intrapartum to prevent OASIS in general?
See, mainly we should good monitoring. Intrapartum monitoring is very important. That is what we need to know. And then, you say very good support, and if indicated, give an episiotomy. And not only that, even causing OAC, you have to recognize it and suture. That is one. And even when you suture, your documentation and all has to be perfect. Like, what was the stage of the injury which you saw? And what did you suture? What suture material have you used? And what are your follow-up? And also we need to counsel them that by and large, all of these patients heal well, but sometimes we need to get into trouble. So if you follow an adequate care throughout delivery, the episiotomy suturing, even if you think it is a normal episiotomy, that's always I tell them, this one finger, you remember after vaginal delivery, please do a PV and take off all the clots, and then also put in a vaginal finger into the rectum and see if there is any OASIS. And if there is any OASIS, always shift to the theater where you have good lighting, good positioning, and already both the patient and the obstetrician are tired. Don't go and flog her. Do the suturing under a good anesthesia. And like we say in BVF, the first repair is the best. Here also, the first repair is definitely the best. So in case you are not trained, you can even wait a few hours or minutes, or try and call a person who is good at suturing. So causing an OAC is not a medical negligence, but in case you don't know, it's better to call for help. And always it is better to document what was this injury and what you have done, and what is the counseling you've given, and the follow-up.
Ma'am, Dr. Vijayalakshmi ma'am and Dr. Gopinath, sir, would you like to ask any questions pertaining to this page?
Can I?
Yes, ma'am.
Yes, Meera. No. This is just about a small case which I had. It was, in fact, in all these years, the first time I saw that. She had a normal delivery, no issues. Of course, the juniors do the stitching and everything, but we are there. But all went well. One finger in the anus as usual, all fine. No anal damage or sphincter damage. Now, discharge comes back after about a week saying anal incontinence, and we are a little worried whether something was missed in the anus or the rectal examination.
Sometimes when we see patients like this, we have seen that a buttonhole tear in the rectum has been missed.
Yeah.
A gentle separation alone, they would have thought, they've seen the sphincter, it is normal, and the episiotomy is normal. So with just a little examination, cursory examination, they think. So you must insert, a bi-digital examination. You put your finger and see. Many a times we come across a scenario which you are telling, where it was found that is a buttonhole.
No, I'll tell you. So what happened?
Though it doesn't come under the OAC classification, it is still common.
Yeah. Anyway, it looked all intact. All that had happened was at the apex. You normally go a little above the apex to stage. So something has been missed, or maybe loosened or whatever. And then there was some bleeding in between. that is behind the posterior vaginal wall.
So when they took a
And
bite, they took a bite deep into the rectum.
And there was some, no, it didn't damage the rectum at all.
Okay.
So that there was a complete one channel of blood clots behind the posterior vaginal wall. And probably that was irritating or giving her that symptom. The moment we opened the episiotomy, of course, we did it in theater because, you know, always you worry a little more. And then when we opened, there was nothing. The blood clots, we took it off, resutured the episiotomy, and she was fine. This, that is, she presented within a week. I mean, after a week or roughly after a week. Of course, it was hard
a big vulval hematoma kind of when you saw them?
No, there was nothing. In fact, by palpation, we could feel something, you know, like how the episiotomy heals with a little bit of fibrosis. Something we thought that is a thing.
Duration.
But we opened up at the episiotomy incision site, just opened it up, and there was one complete string of blood clot pressing there. Probably that was giving her the sensation. And after all this, she was perfect and nothing happened. So we don't know whether sometimes even smaller things give a bigger symptom.
Audience.
And you have to be careful with every step. Yeah. Thank you.
Ma'am, take-home messages for the audience, please.
Actually, yes. The thing is, you know, careful intrapartum monitoring and not relegate the suturing of the episiotomy to the junior-most person. I mean, I'm not against a junior-most person suturing, but it has to be under supervision, following all the basic precautions like what I was telling, a rectal examination. And in case there is a doubt of OAC, it has to be evaluated and sutured properly in the theater under anesthesia by a person who knows how to suture. You know, you try and do something. Many of the times when we get patients, it has been recognized, sutured, but not sutured the right way. So it has to be sutured the right way. And then the next thing is a good follow-up and instructions given to the patient.
Thank you very much. Thank you very much, ma'am, for joining.
Thank you.
We then move to the final aspect of today's webinar. So may I request Dr. Sanjay Pandey to join us. Hello, sir. Is Dr. Sanjay Pandey here?
Dr. Meera, good evening.
Good evening, sir. Welcome. Thank you. So this patient is a 47-year-old Rajasthani woman presenting with complaint of dysuria, pain and pressure over suprapubic area, 4 years, treated as UTI multiple times over the last 4 years, long-term antibiotics as well. Increased frequency 20 times per day, disturbed sleep and urgency. I think I've said enough. Subclinical hypothyroidism, not on any treatment, and just a shoulder ligament pain. Examination revealing a normal external genitalia, normal urethra, but anterior vaginal wall tenderness and no prolapse. Urine analysis normal, so that now rules out a possibility of a UTI here, and an ultrasonogram which was normal. So what would be your assessment of this patient, and why are we considering urine analysis an important step?
Sanjay sir, could you unmute yourself?
Unmute,
we
sir.
cannot hear you.
I'm actually now on two devices. Sadly, something is going wrong in the audio on the laptop. Am I audible to you?
Yes,
Yes.
sir.
Yes.
Okay. Only for the reason that I need to see the slides. I've kept my laptop on. Something went wrong in the last 45 seconds when we started. So it's okay. So you did talk about Rajesh. Can you just go back to the slide, please? "47 years old, complains for problems since last 4 years, treated multiple times for entity called UTI, long-term antibiotics, and now she has got frequency multiple times a day and disturbed sleep and urgency." Great. Okay, can we move on? Normal urine analysis. So what is the importance of urine analysis? So you want me to take the questions one by one?
Absolutely.
Okay. So you have a woman who has been labeled as recurrent UTI or chronic UTI for the last 4 years, taking antibiotics. We must believe two things. One is possibly that she was getting a recurrent UTI, number one. And possibly there was a situation that she may have been misdiagnosed, may have been given antibiotics for a long time. While her symptoms progressed or symptoms stabilized, she continued to have discomfort, and the discomfort is all about day and night. So the importance of urinalysis is to rule out a UTI at this point in time when she presents to us 4 years after her initial symptoms. It's important for us to look at both a midstream urine routine and a midstream urine culture, and gives us all about what we wanted to know, which means that does she have a microhematuria? Does she have a UTI? Remember, when we look at the routine UTI workup, which we look at in a urine analysis for a lady who is getting recurrent UTI, we are looking at the last picture of those intestinal bacteria which are picked up normally. But we sometimes miss out, and we need special cultures for everything in that age group where she belongs to, which includes Chlamydia trachomatis and Mycoplasma hominis, etc., which we will never be able to pick up, number one. So if there is increased number of pus cells, we are aware about that. We're dealing with other entities too, which includes, in a country like this, a possible genitourinary tuberculosis and other aspects. Very important for us to wake up to that. Today, we have gene expert to pick up things early or look at cultures and possibly move up the ladder to identify stigmata of those problems. You're talking about a threshold of doing a cystoscopy in the lady. I would actually go back to the history and look at that she's going through the situation. I would look at giving a patient hearing to the whole situation. That means the history that you have evoked is good enough. That means women go to gynecologists for this issue, and rightly, if she comes to you and to all gynecologists esteemed in this audience, the aspect would be to actually go deeper into the history and to identify those aspects which we need to pick up. That is the crux of the matter today. That means fundamental to the clinical diagnosis that we are still hovering around. We will look at that. We pick up all those things which are her voiding symptoms, her pain characters, and obviously the trigger points that have actually kept her ongoing from recurrent UTI symptoms to a possible pain and continued situation that she has, which means that to identify that, more of history taking and obviously a bladder diary. So I would look at a urine analysis, a urine culture, identify that is she presently in UTI? Possibly no, number one. Number two, to go back to the basics of a bladder diary will give us a lot into what we had discussed in the previous two of the discussion that we went on. Gives us an idea not only about the frequency, urgency component. Don't forget that these patients fundamentally have got everything to do with sensation, which is unpleasant and uncomfortable. That means a discomfort arising in the region of the pelvis would require to be looked at in a bladder diary, which is an extended bladder diary, where we'll look at pain component, and you would identify that she has pain during bladder filling. She could have pain otherwise too. So that could be a component which will give us an idea about a pain as a trigger point arising from the pelvis or the bladder. Would you image the patient differently if the pain was not that significant?
So the pain was not a major component.
Yeah, if the pain was not a major component and she had only recurrent UTI, I would image her as if I would evaluate the lower urinary tract, which could be genesis to problems on the upper tract. But I would always look at starting with lower tract, even if the pain was a component, which means that I've not yet gone into cystoscopy. Now, cystoscopy is an invasive approach, and to look at somebody who has gone through the agony of all this, but stayed stable and probably wants to break the threshold of her activity that she has gone through in terms of management with long-term antibiotics and approach, we look at identifying her more. And that's where history and clinical examination, I think going deeper into it can pick up a lot. So imaging would still be an ultrasound to start with, which would give us a lot of crux of the matter, like the kidneys, possible scars. I'm going deep into that understanding, going down to the bladder, looking at a bladder wall thickening, giving us an idea of bladder trabeculated, looking at a post-ward residues, and then move forward on that non-invasive approach of still evaluating the lady as she comes on day one or maybe the second visit, a uroflowmetry, which is a lot of I'm deeply interested in. I've still held the cystoscopy for a short while because I'm still assessing her and giving her a chance of giving me all the inputs which I looked at initially. That means looking at the trigger points, looking at the association of her other comorbids that she could be having, the pain characteristics, and identifying her more, which may not have been asked to her in the era where she was treated only as a possible chronic or a recurrent UTI. So what would be your approach if the patient also had difficulty in bladder emptying? And that's where I come to. If a woman is of that age, 47, perimenopausal, could also be developing issues where she could have difficulty in bladder emptying. So one way, she could be having urgency, frequency, and pain, which she already has. And on the other side, she has got issues, which includes a possible bladder emptying story. That means I would look at a uroflowmetry with a real understanding. I would look at a non-invasive, already done ultrasounds that she is carrying and looking at the residual volumes. But uroflowmetry is the crux of the matter. That means the approach is to identify and look at that it should not be an obstructed lady getting a recurrent UTI with high post-word residues and that DNA fingerprinting or still bacterial colonies residing in the bladder. So your pointers on the bladder pain syndrome here is number one, looking at the history. 47 years young lady who has actually lived those 4 years when an American president would complete her term, still in agony about one disease called recurrent UTI, chronic UTI. Antibiotics for so long. And now she has got those important pointers which we need to extract from the history, which has not thoroughly probably treated or cured her. And those pointers are very classically her discomfort, which could either be an alternating discomfort on and off as flares and recurrences, or could be an ongoing continuous discomfort down there in the region of the pelvis. So that could be a great pointer, which would look at that she could be arising of a situation which could be bladder pain syndrome. She doesn't have urine cultures or analysis as a pointer of a UTI at this point in time. Her bladder diary talks about, in her language, on the first slide, he talked about discomfort at night, discomfort in the day. You and I wake up with urinary sensations, go and void and go to sleep. Her nights are about getting up in pain when she is deeply asleep. So threshold is about pain that wakes her up. So the pointers of bladder pain are, she does not have urine cultures which are positive. Number one, she has got discomfort arising from the pelvis, which is not unfortunately being managed to the point that she would deserve it. And therefore, we would look at all those. Now remember that there are no specific pointers towards looking at her as inclusive. He is already talking of all that. Therefore, it looks like that we would look at investigations towards moving forward. Now, what would it mean? It would mean that I would look at urine analysis with a pinch of salt, microhematuria or no hematuria. I would look at that she has suffered for 4 years from that aspect. Is bladder a cause of pain or bladder is not a cause of pain? And therefore, Dr. Meera, I like to point out something very important today, because that is something which my colleague gynecologists and urologists would like to look at. That somebody has got bladder filling evoking pain in a bladder pain syndrome does not in itself distinguish between bladder as a pain generator or bladder as a pain referral site, which could be either originated from some other site. I'm talking about a central sensitization which could have developed over 4 years of discomfort, and we have labeled bladder as the cause of it. Getting a point? So obviously cystoscopy could be an aspect to look at, because she has lived for 4 years on this discomfort, while we're looking at so-called innocuous disease which has taken life out of her for the last 4 years. We should not be missing things in our location, which could be a carcinoma in situ, which could present very similar to the irritative voiding, discomfort and pain, which could also be a case of tuberculous cystitis or lesions in the bladder that we would like to know. So from a very non-invasive approach across the table to attempting to reach to her in terms of empathy, in terms of understanding her symptoms, scoring her out. And remember, pain, pain, pain. On one way, she has got sensations of urine, which includes urgency, frequency, dysuria. On the other side, she has got all that. So the dysuria you mentioned may not actually be a dysuria per se. It could be a highly acidic urine causing dysuria. Number one, she is afraid of drinking water. Or it could be a burning sensation in the introitus, which they probably call as sharp and stinging and discomforting. So many times the word dysuria has actually also been wrongly used. Very important to wake up to that phenomenon. So if she has dysuria and she has a urine analysis showing an acidic urine, probably alkalizing the urine itself helps. If she has dysuria with urine analysis and urine culture showing that she has got positive cultures, she possibly is a case of UTI, where after evaluation, we do a bladder diary, identify her symptoms, along with that, the urgency, frequency, and then take cultures positively and look at the uroflowmetry and identify that she doesn't have an obstruction. So a large picture of a confusable phenomena where for 4 years she's seen colleagues both in gynecology and urology. We look at cystoscopy at a point in time and possibly move forward. Biopsy would only come if there are visible and measurable lesions during a cystoscopy, which is always under general anesthesia.
Always. Thank you. So we made a diagnosis or made an impression of bladder pain syndrome given the pointers and the history, negative culture as you enunciated, and the long duration with which she is disturbed and the quality of life impairment. So what should I be doing now for this patient?
Yeah, so that she has gone through all this bladder pain syndrome. For the sake of colleagues, I must take this little forward. Give me a minute on this, because though I understand we're getting a little late, but this very important aspect of bladder pain syndrome directly put by you brings us to a point that we have done all the evaluation, identified her, and she is a case with a chronic phenomena of discomfort in the region of the bladder with all the urinary symptoms which are uncomfortable to her. That means a therapy of a kind where dysuria, 1, discomfort, number 2, urinary symptoms of urgency and painful bladder filling are all need to be treated. So I think we'll get into the understanding of treating pain on one side, the pain of distensions, the pain of discomfort of a visceral organ. We will look at taking her on the urgency frequency component, and that's a great empathy to get her not 20 times a day voiding, which is quite uncommon, but sadly she goes through it for the last 4 years, and maybe it be progressive. We also look at improving her days and nights. So she will get a kind of a cocktail, I would say, of therapy to start with, which will be a measurable treatment on 2 aspects. It will be both diagnostic and therapeutic. Remember that bladder pain syndrome does not have a laboratory test or a diagnostic test or anything around. So your diagnosis hinges a lot upon patient discussion, keeping the patient in the loop and getting her back again and again to look at it. So our therapy revolves around keeping her pain-free. So what gives her pain-free is that the bladder lining, the bladder pan epithelium being disturbed, there could be inflammation along the bladder, and there could be bladder lining disappeared or not replenished could be the issue. So we start her on those therapies which decrease the bladder pain. Over the years, I've understood that these patients do accept 25 and 50 milligrams of pregabalin as a nerve modifier, and that's a great stuff to start with to think about. Though we look at hydroxyzine on one side, we look at amitriptyline on the other side as relievers or nociceptive stimuli activity. We also have looked at that your examination was completely non-confounding. That means clinically there was nothing else to look at. A vaginal examination, no vulvodynia, no vestibulitis, no pelvic floor muscle dysfunction or spasms, and there were no trigger points or myofascial bands. We would look at that aspect with a lot of depth. Because as I was trying to tell you, that the bladder pain syndrome, the entire concept is about the uncertainty of the central sensitization. You want to get her pain-free. That means in each aspect of evaluation, you will be looking at her pain and getting her pain down, because the lower spinal cord, which actually imbibes the afferents both from the viscera, from the lower pelvis, which includes the rectum, the bowel, the uterus, and the bladder on one side, and the somatic aspects, they all actually converge to the afferent nerves. And therefore, I was trying to tell you that the entire aspect of noxious stimuli arising from a pelvic organ and the perception of pain in another organ could be a possibility. Therefore, bladder may not always be a seat in a case of bladder pain syndrome. And therefore, we need to look at the aspects of pelvic floor and looking at other things which have not been diagnosed around. So obviously, looking at the pain therapy, I would start her on all aspects of pain, which could be the pain arising in terms of spasm, pain arising. So the vicious cycle of pain will be treated forward by looking at possibly giving the local names of atarax, possibly giving the local names of sensival, possibly giving her a small dose of pregabalin, escalating it to a level that would help her. So gabapentin and pregabalin in measured doses, where a patient is confident enough, could actually help in that neuropathic aspect of pain treatment. On the other side, she has got gross frequency urgency. If the uroflowmetry and her own voiding diary and her own voiding stimuli talks about non-obstructive aspects, I would look into getting her overactivity, which is more result of her not being comfortable because the pain would come back as a noxious stimuli, that she goes and passes urine multiple times. So the bladder fills up earlier than normal because there's an early sensation of the bladder, would dampen the bladder contraction. And that's where the choice could be by default either the antimuscarinics, 5 milligrams of solifenacin, or 25 milligrams of mirabegron, arise up to goes to 50 milligram mirabegron. So these are the aspects that I would start with. Pain and urgency frequency. If that is what you've taken care of and the urine does not have any culture issues, she is much more amenable to the kind of therapies you would take her in back. I want to also give you that, Dr. Meera, there is a small subset of patients who come with the kind of flares she has come in, is where the intravesical therapy is a very good add-on therapy to build the confidence to bring her out of this completely radically from A to Z, which means that an intravesical therapy in the background of continued oral therapy is a great stuff. That means you are going to give her intravesical silence. And that therapy is practiced by me at least in the early phases or in the flared up phases twice a week to start with, which could in the second or third week bring about that result which is added upon by the other therapies that you started around. Obviously, we're going to spend time in talking to her regarding her self-care, her behavioral therapies, identify the stress which she goes through, both physical as well as mental, and coping with those stress techniques as and when she gets a flare-up. So that will be a kind of a cocktail that you would start on all aspects.
So, as we said, we went through all those medical therapies because at that point of time when she came to me, she was telling she was suicidal because her husband is a biker and she would go along with him. But nowadays, she's not able to take the bumpy road ride. So, which was pretty much interfering into their relationship and also her intercourse and everything. So, she was almost suicidal at that point of time. So, we proceeded to do a cystoscopy, and that showed a Hunner's lesion. And I would like you to elaborate for the benefit of everyone about what potential cystoscopic findings we would find in these kind of patients.
Absolutely. So you are talking about bladder pain syndrome where you have got lesions to talk about. That means you have got lesions. So let me discuss this. This is important. Hunner's lesion is, let's just go back and remind that Leroy Hunner was a gynecologist. So giving the subject back to gynecologists, number one. Number two, we are looking at the patient on a cystoscopy under general anesthesia where we enter and look at the bladder and identify the bladder as a whole. Identify and look at what does the bladder look like. That means the bladder's lining, the bladder's capacity, the bladder's landmarks, which includes the ureteric orifices, the dome or the air bubble up there, the bladder neck, and look at the bladder as a whole, quadrant by quadrant. I gather that there were at least, I can't see the slides, but there were at least 4 bladder lesions which look like Hunner's ulcer. Hunner's lesion, sorry.
Shall I put it up?
Yeah, that's fine. I cannot see the slides at this point in time.
There were 3.
Yeah, so three Hunner's lesions at this point in time. So
are we able to see anything yet? No.
It doesn't matter. It's okay. I cannot see the video clips. Your written intro of video clips, I cannot see any of them.
Okay, that means
dark, but doesn't matter. So what you did was you did a cystoscopy. You picked up those 3. That means you have got global lesions in the bladder. Those are the kinds of discomfort that she goes through. So let's look at that. Patients with Hunner's lesion compared to the non-Hunner's group are the patients who are more uncomfortable. They are the ones who actually go through the entire phenomena of looking at, so the patients with Hunner lesions are the more uncomfortable patients, who have more severe kind of symptoms, who go through more discomfort that they go through. And you rightly, on a cystoscopy, which you decided to do because the patient had already suffered for 4 years, and we have been labeling her as UTI and recurrent UTI, a cystoscopy gave you findings, which actually was very important. So to me, at this point in time, it was extremely important to identify that this patient gets the benefit of what she deserves. What she deserves is the fulgurations that were done rightly. The fulgurations are to actually destroy the Hunner's lesions, which actually are central scars with radiating telangiectatic capillary vessels, which are visible. Sorry, I could not see your videos, which could have played. But we look at these lesions are those lesions which actually are a component of interstitial cystitis as defined by the NIDDK in 1987 when I joined medical college. So IC has always been a component of histological and pathological features compared to bladder pain syndrome, which is more of a symptomatic approach to take the patients forward. ESIC, what it did was it combined both together, and therefore we call it as bladder pain syndrome, interstitial cystitis as a combined disease group, which finally we are separating in due course of time. What you have is the Hunner's group, which are more difficult patients to treat. They go through the agony. Their discomfort levels and their flare-ups are more difficult. So I gather that these patients would undergo that cystoscopy, fulguration or resection of the lesions. Obviously, that would go for a biopsy, which will have little meaning because the very picture very classically talks about the lesion is being treated. Obviously, at that point of time, there was a microhydrodistension, which happens, and these are beneficial aspects around. Remember, you are also using cocktails at some point in time, which I looked at. That means intravesical therapy is a great therapy for patients where the bladder lining gets that silence or the hyposensitivity instead of the hypersensitivity they go through. So many patients, for the sake of audience, need to be taken care of by decreasing the sensitivity, decreasing the discomfort by oral therapies or by intravesical therapies. In between these two is the cystoscopy, which we need to tailor ourselves and look at who deserves early cystoscopy, patients of that kind who have got significant symptoms, more common flare-ups. The flare-ups are those which are exacerbated by either food or by premenstrual periods or by various kinds of UTIs, which actually flare up the bladder urothelium. One question which I never answered to myself or to the society is, why do women get more IC bladder pain syndrome compared to men? And that's where the question comes, is because possibly the UTIs were the cause of denudation of the urothelium as one important landmark aspect which patients go through. So cystoscopy, looking at the bladder, you could find one aspect where the patients could have Hunner's lesion, or patients could even not have Hunner lesion. And that's why I told you that the trigger point of a visceral organ and getting a trigger point to the pelvis could not necessarily always be bladder. So that's your cystoscopy. I can see the video right now. And
good.
I can see the video right now playing in a slow motion. And I gather at some point in time, I can see clots here, which is, keep going ahead. So the vision would be better in your laptop compared to what is being transmitted. But I see gross erythema, and that's right. Those are Hunner's lesions. For sake of colleagues, the central area of the white scar, which is covered by coagulum and by fibrosis, completely fine. You are in the bladder neck and you reach directly on the bladder, on the posterolateral wall, you find those lesions. So the techniques to deal with such lesions are obviously a fulguration or a resection, which could be laser or could be a transurethral resection. Remember, the bladders are diseased, therefore the thin kind of resection that we do around is fine. You're removing the clots and you would then go do a fulguration on these aspects. So those areas are diseased. Them to have a normal urothelial lining will not be possible till the disease, central scar with coagulum, with fibrosis, and the telangiectatic vessels as an entire lesion is abolished. There has been talk about triamcinolone as an aspect. I have little idea on that, but I do a similar kind of stuff that you do, which the world does. They resect those areas, fulgurate those areas. Fulguration comes when the bladder wall looks too thin. Are you going to do in a partially full bladder? Not in a completely full bladder. The risk of these bladders being diseased and thin could actually cause trouble with perforations. Once you have fulgurated or resected these lesions, you have had those areas denuded of the lesion per se, which are globally seen in your disease state. If there are any strips which could then be sent for a biopsy, good enough. But otherwise, you have fulgurated and you have abolished these lesions. I can see them being done step by step. You saw the orifices on both sides. You travel up to the supra-trigonal area, you pick up those. And while you have actually converted yourself from cystoscopy, emptied the bladder and taken the receptoscope, you've encountered the bleeding as a result of these ulcers or the lesions which could have torn, and those clots are visible. So classically, these are not normal looking bladders. These are more symptomatic patients that deserve a therapy, and the therapy here becomes close to a cure for many patients. Believe me, that very important humbug of these patients having a lifelong disease is not right. We need to bring a deviation to the natural history of the processes rather than see suffering a lifetime of 4 years going through all this. So rightly, these patients thereafter, as the bladder lining is going to come back, would be treated with intravesical installations as a more closer therapy to the bladder. Her discomfort on the bladder sensations, which could also be an oral therapy that she continues to accept, and her sensitivity and her urgency frequency could be handled best by other kind of therapies, which includes overactive bladder therapy on one side, pain therapy on the other side. And because these bladder linings can be best improved by giving possibly sodium pentosan polysulfate, which even works also as a monotherapy for many of these symptoms which are on the lesser aspect, we could start managing that. So it could be a combination of all this that we will do, and that was rightly done in your patient.
Is biopsy always mandatory? Because this is a totally abnormal bladder, but to suffice ourselves just by visual inspection that this is only a interstitial cystitis is it's difficult to convince ourselves and rest. For those kind of instances,
got it,
to make sure we're not missing out anything.
Perfectly fine. So cystoscopy brings about two broad pictures. One is with lesions or without lesions. Bladder pain syndrome is a clinical diagnosis where pain, pressure, or discomfort arising from the pelvis with relation to urinary symptoms is what you've defined. Because the symptoms are too difficult, you do a cystoscopy and get inside. You may find two different phenomena. Either you may find the bladder to be completely normal, or you could find bladder with lesions. The one lesion that you showed are florid lesions kind of thing. which in this Indian subcontinent you would also find in tuberculosis. So carcinoma in situ, tuberculosis, eosinophilic cystitis, various kinds of non-metaplastic issues, and cystitis glandularis kind of pictures which appear around. Any lesion needs to be either removed or biopsied, number one. Number two, not necessarily that you would be looking at biopsy in all cases. For example, if your bladder mucosa looks completely normal, she could still be a bladder pain syndrome. Let's remember that. The IC and painful bladder syndrome, as given to us by NIDDK1 and by the International Continence Society in 2001, was a conglomerate of definition. That definition was moved forward to understand now that bladder pain syndrome not necessarily will always have a cystoscopic stigmata. So you will still be convinced that this is a bladder pain syndrome because, as I said, a visceral organ giving a pain could not necessarily be a bladder. But bladder is the seat of this because it could either be a site of noxious stimuli and allodynia resulting from as a referred pain site. It could be from various organs. Therefore, let's not forget that bladder pain syndrome does not require only a gynecologist or a urologist, but also includes a physiotherapist and a pain therapist. We abolished the word called Kegel's exercises in this because you don't want to stimulate muscles, you want to relax muscles. And therefore, clinical examination and understanding of myofascial bands, which for the first time has come in urological literature in the latest edition of Campbell, talks about where a physiatrist and a pain therapist is very important. Pelvic floor muscle dysfunction and spasms also pass noxious stimuli and afferent stimuli to the second order neurons, spinal neurons, which could be a similar kind of pain. So cystoscopy not necessarily always will give you lesions around. You don't get a lesion, don't label the patient as non-bladder pain syndrome. The bladder pain syndrome still is a clinical definition, which in the first, second, third visits, out of your therapy, she is already improving. While on the other aspect, she actually has got a discomfort, which could be picked up. And so I think we're balancing around. Not all cystoscopies will give you findings, but cystoscopies to rule out while you are progressing on a therapy or progressing on the course of a cascade of problems. You don't want to miss out diseases like carcinoma in situ, like cystitis glandularis, like tuberculosis, etc. You pick up something, you're not necessarily going to biopsy all the time, but you're going to look at it. That means anything which is suspicious will be biopsied, anything suspicious will be fulgurated and removed because you want a normal urothelium to come in. And that's where I did talk about sodium pentosan polysulfate, which could be a great leveler in terms of helping those patients to be either intravesical or oral, help to remove this denuded epithelium, which is denuded either by the disease or denuded by our fulguration laser or probably removal of the lesion.
Excellent, sir. So this patient subsequently went on to have this fulguration and is on intravesical therapy on a weekly and then subsequently fortnightly basis. She does continue her oral pentosan, but I believe that is going to take time to regress her symptoms. So considering that we've dealt with all the aspects of bladder pain syndrome, what are the three key take-home messages you would like to give the audience while dealing with somebody with the pain, frequency, urgency triad when they present?
So with pain, frequency, and urgency triad, a woman who's suffering from a chronic condition, which is anything between 3 months to 6 months or beyond, like the woman here in question has spent 4 years in the agony of it, it is a progressive phenomenon. It's not only progressive somatically, it's also progressive psychologically. Because there are no diagnostic tests either clinically or laboratorically or not necessarily always cystoscopically, a patient could be labeled as possibly a psychotic. This patient, which Dr. Meera Raghavan presented, was also psychotic in terms of near suicidal, because for 4 years, the treatment was possibly going on one aspect, and we may have missed out, not necessarily everybody. So the first and the most important thing is women suffer more frequently with UTI and recurrent UTIs than men. Number one, women suffer from bladder pain syndrome more frequently in the ratio 5 to 9:1 compared to men. That means we need to use our thinking caps on and look at the two kinds of patients we see. Those whom we have been seeing who are refractory to various kinds of therapies in the pelvis that we have done. And they could be those patients whom we may have treated or could have concurrent issues of endometriosis, pelvic floor muscle dysfunction, could be having an overactive bladder failure, where overactive bladder treatment, as very well defined in the last lecture, could actually not have helped her completely. So we are identifying those kind of patients. That somebody has got a pain on bladder filling and gets some relief to complete relief on bladder emptying, like a sine qua non symptom, may not be common in all patients. That means patients do have almost forgotten that they got relief. Many of them go through a central sensitization where the spinal neurons would give discomfort to somatic areas, and bladder being that large crux which fills up and filling up a viscera gives us a pain. we label it as a bladder pain syndrome. So women going through this more frequently, women go through respected gynecologists, and therefore gynecologists in this entire August audience today on a wonderful webinar happen to be the first crux point all the time. So if you have new patients coming up with pain arising from the region of the pelvis, along with frequency, urgency, and discomfort, your clinical examination does not point to a vulvodynia or a urethral syndrome or a vestibulitis, and there is a discomfort on the pervaginal examination at the level of the bladder, there could be a situation where there could be a patient who could be even an interstitial cystitis. On the other side, if somebody has got myofascial band, somebody who has got various kinds of perineal pain, vulval pain, perianal pain, not related to urination, which we and you have labeled as dysuria, but this is only introital burning pain of the kind that they describe best. It is important to use the jargon and the terminology that the patients speak up, and therefore the confidence building on the patients are important. So to us, identifying the disease is not necessarily of exclusion, but also of inclusion, that you include points which are pointing away and taking away other aspects around. Obviously, many of these women will have irregular menstrual periods, and you will add on other aspects towards therapy. But looking at the bladder pain syndrome being a progressive disease, unless you halt the natural history of the disease and deviate it towards a point of preventing an end-stage bladder in the IC group, it is important for us to have a low threshold on few things. Low threshold of moving up the ladder very fast in patients who are severely symptomatic, get significant flare-ups, and possibly treat them with a combination of oral as well as intravasicals. Intravasicals happen to be both diagnostic as well as therapeutic. So if you had somebody whom you put lidocaine and bupivacaine in the office and left them 30 minutes outside and then ask your secretary, how is the patient feeling? And the patient comes back and say, you gave me relief which was never in the last 4 years. I think you've got a lot of answer. So to come to the concluding point that we need to wake up to these phenomena, these patients are treatable. They go through domains of multiple aspects. Somatic on one point, psychotic on the other point, and the discomfort of passing 20 times a day, getting up at night with discomfort. If all these things are happening, please keep low threshold on multiple aspects. If these patients are of the age of 47 and beyond, then they could be having warding dysfunction. They could also be having mixed incontinence. That is the only aspect when I would add a urodynamics as a part of a workup. Otherwise, the urodynamics could be well answered by a warding diary and by a uroflowmetry. So coming to a close, this entity is not uncommon. It is also to be not underrated or overrated, but I think we need to spend time thoroughly again and again on history taking, discussing these patients, examining them, taking an opinion, second opinion, building up a team, having a gynecologist in my team, having a urologist in your team, and finally a pain therapist all the time. Also confidence building of the relatives who think there has been no complaints, doc. We have got thick files. We have seen the best in the business, and they've said there is no disease anywhere. That's where you build up confidence by relieving these patients of the discomfort, which is most important. They get back to the life. Then you relieve them of the urinary urgency frequency, which is beyond overactive bladder. So go back to your refractory patients, go back to your new patients, and wake up to anybody who complains of pain as one and pain related to urinary findings around, and then combine together and help them out. Thank you so much.
Thank you very much. Thank you one and all for a fantastic webinar today. We have gone through absolutely every single domain of female urological issues and urogyne issues, starting from Professor NRM to bladder pain syndrome, which concluded by Dr. Sanjay Pandey. Thank you, all the esteemed chairpersons, all the expert panelists, and the wonderful delegates who patiently stayed on to probe into every single domain and every single case study which we have today. Some extremely specialized, but some which are our day-to-day occurrence where we find them difficult and complex to manage. Nevertheless, it has been such a wonderful, exciting, interesting 3-hour journey. Thank you one and all. And thank you, IPCA, for enabling this to happen and your wonderful AV support and organizational logistics. Thank you.
Thank you, Meera. That was wonderful. Really different type of a webinar. And thank you for the opportunity. And I really learned lots of urology. Thank you so much.
Thank you.
Thank you, Meera. Thank you. It was really good.
Thank you very much, ma'am. Thanks for the participation.
Thank you so much.